Hi everyone, a very good morning everybody, and my goal today is to do a quick and rapid revision of radiology. And in this session my goal will be I will use approach that I use in a regular classroom. I will not use the DVT approach. I will use the approach that I use in the regular classroom, but I will try to keep it very crisp. And second thing that I'll try to do is I will try my best to, I have taken a blank sheet with me. You already have a labeled sheet, and whatever I will write down, I will give the sheet to you. So my goal for you is if you can just keep answering in the chat box, don't write anything. If you are, attending my class for the first time, maybe you can write down, but if you don't want to write also, it is okay. All you can do is you can directly take the annotated PDF and revise it later on. So I will be annotating the PDF with you, and I want you to use the direct PDF later on. No need to write down, but if you are attending it for the first time, there's no harm in writing also. But my goal will be a rapid review of radiology. Are you set to go? Give me a thumbs up if you are ready to go. Okay, so if you're ready to go, let us label the first image. This is a CT scan of the brain. How do I know it is a CT scan? Because I can see the bones are appearing white. And what type of section is this? This is a axial CT of the brain. This is a axial CT scan of the brain. I am labeling the first structure as 1, second as 2. All you need to do is keep typing and tell me what is 1, what is 2. What is 1, what is 2? 1 is your orbit, 2 is your sinus. Air has a Hounsfield unit of -1000. As a result, it is appearing black. So air is appearing black. What is the structure marked as number 3? So I'm labeling it all for you. Don't worry. You can just take this PDF again and see it. Number 3 is your temporal lobe. This is where you look for herpes encephalitis. This is where you look for herpes encephalitis. Can any one of you tell me what is the structure labeled as number 4? What is the structure labeled as number 4 in the image? Number 4 is your sella turcica. This is where your pituitary gland lives. Sella turcica. Very good. Can anybody tell me now what is the structure marked as number 5? Number 5. Number 5 is the part of your posterior fossa where you have the balance organ called as your cerebellum. Okay. What is number 6? What is number 6? Number 6 is this broad area that you see in the posterior fossa. This is shaped like a bridge. It has to be your pons. This has to be your pons. Okay. And I'm very quickly labeling in this rapid revision video number 7. Number 7 is your fourth ventricle. Number 7th is your fourth ventricle. Okay, bacho. Now, anyone can now tell me what is this area that I'm labeling as CP? CP. This is your cerebellopontine angle. Cerebellopontine angle. So this is the revision of the anatomy of the section of the brain that I am showing you. Let us review another section of the brain. Okay, bacho. Identify the structure marked as 1. Identify the structure marked as 1. I have never seen more intelligent students than I see in the chat box right now. What is the, tell me, structure marked as 1? Frontal lobe. Structure marked as 2. 2. Anyone? Temporal lobe. 2 is your temporal lobe. In the temporal lobe, I am labeling 3, 4, 5. In the temporal lobe, in the mesial part, I am labeling 3, 4 and 5. What is the structure marked as 3? 3 is your amygdala. 4 is your uncus. The medial most part is the uncus. And 5 is your hippocampus. 5 is your hippocampus. Okay. Now everybody try. What is the structure marked as 6, 7 and 8? 6, 7 and 8. At number 6 we have pons. 7 we have cerebellum. 8 is your star-shaped CSF space called as suprasellar cistern. 8 is your star-shaped CSF space called as suprasellar cistern. So this one, the star-shaped area is your suprasellar cistern. Okay. So let us quickly revise another section. I am going from below upwards so that I keep giving you the anatomical revision. Because if you notice in my DVT, my goal is integrated pattern just like the NEET PG. Here my goal is to talk about the revision pattern. Okay, beta. 1. Identify the structure marked as 1. 1 is your frontal lobe. Okay. 2. 2. 2 is a fissure which you see in the lateral border of the brain. That is your Sylvian fissure. That is your Sylvian fissure. Let me maybe use a better handwriting, because I will give you this PDF beta, don't worry. Some of you are worrying, don't worry beta, hai na? I'll give you this PDF. So that's why I'm writing very clean so that you can easily revise. Okay. Number 3. Number 3 is your temporal lobe. Why this is not parietal? Because you can see the Sylvian fissure. Anterior to Sylvian fissure frontal, posteriorly temporal. Number 4 is your cerebellum. Number 4 is your cerebellum. Can anybody tell me what is the structure marked as number 5? What is the structure marked as number 5? Number 5 is your midbrain. It is shaped like a heart. That is your midbrain. Adjoining the midbrain you have the uncus. Adjoining the midbrain you have the uncus. So that is why the midbrain is compressed in the uncal herniation. Anterior to the midbrain you have the interpeduncular fossa cistern. Interpeduncular fossa cistern is bounded anteriorly by the optic tracts. So that is your interpeduncular fossa bounded anteriorly by the optic tracts. Are you able to see this white colored area beta? Anyone? Can you see this white line? Yes, that is your falx cerebri. That one is your falx cerebri. Okay. So I'm trying to give you a quick overview of the anatomy of the brain. So anyone can answer now. This white line is the falx. Anteriorly you have the frontal lobe. Behind the frontal lobe you can see the Sylvian fissure. Can you see the Sylvian fissure beta? Yes. This is your temporal lobe, occipital lobe. All I want you to tell me is what is the area deep to the Sylvian fissure called as? This area is called as the insula. This area is called as the insula. This is your insular cortex. How to identify deep to the Sylvian fissure beta? Okay. This is your anterior horn of the lateral ventricle. In the midline you have the slit-like area called as third ventricle. I want all of you to quickly label with me. Let's see if you can label with me in a color. Anteriorly between your lateral and third ventricle, can you see these two columns? I'm zooming in. Can you see these two columns? Lateral ventricle, third ventricle, between them the two columns that you see are the anterior columns of fornix. This is the previous NEET PG question. These are the anterior columns of fornix. Okay. Now once you're clear with this, I'm going up and we will label more anatomy. I want you to label with me. This white line that you see here is your falx cerebri. Behind the falx, okay, behind the falx, I just want you to understand with me, behind the falx you have these gyri. These are your cingulate gyrus. These are your cingulate gyrus. Okay, clear? Okay, now we will label the Sylvian fissure. Still the Sylvian fissure is visible. If the Sylvian fissure is visible, then we are not in the parietal lobe, we have to be in the temporal lobe. These are your lateral ventricles, anterior horn and posterior horn. These are your lateral ventricles. What do you see in the middle? Third ventricle. Third ventricle is present in the center as a slit-like area. Now we will label, together we will label structure marked as 1, 2, 3. Together we will label what is 1, what is 2, what is 3 in the image. Anyone? What is 1? 1 is your caudate nucleus. Adjacent to your lateral ventricle, you should have the caudate nucleus. What is 2? 2 is touching the third ventricle. Okay. 2 is touching the third ventricle. So if it is touching the third ventricle, it has to be the sensory relay organ called as the thalamus. 3 is your lentiform nucleus, which has two parts. The medial part is globus pallidus, outer part is putamen. Between 1, 2 and 3, there is a dotted line which signifies the internal capsule. Between 1, 2 and 3 you have the internal capsule. Okay, very quick question. Identify the disease marked by the arrow. Identify the disease marked by the arrow and why it has happened. The disease that is marked by the arrow is hyperdense. It is more white. Why? It must be a blood clot. Where is the blood clot? Where is this brain hemorrhage? It is in putamen. Why do you have a hemorrhage in putamen? Putamen is the most common site of hypertensive bleed in the brain. The patient must be having hypertension. The patient must be having hypertension. Okay. Are you able to mark all of this? Okay. So I know, if you are starting with radiology first time, you might find them little tough, but I am not talking anything about radiology. I am only telling you basic anatomy of the brain. Okay. Because it is a direct question in the exam. Okay, bacho? Okay. Okay, bacha. One more question. Anyone? Now as you go further up, anyone? You can still see the falx cerebri. You can see the frontal lobe, parietal lobe, occipital lobe. Now because now you are above the level of the Sylvian fissure, you can no longer visualize the Sylvian fissure, then you call it parietal lobe, and you can still see the lateral ventricles. Okay. Between the two hemispheres there is a commissural fiber which I am highlighting for you with a brownish color. This is your, anyone? Corpus callosum. This is how on a CT scan you can identify the corpus callosum. Quick question. In which condition do we see racing car appearance? In which condition do we see racing car sign? Anyone can quickly revise with me. The answer is corpus callosal agenesis. Racing car appearance is seen in corpus callosal agenesis. Okay. Okay. So once you are clear with the basic idea, so far we have seen revised with the brain anatomy, and I have also revised the common things that they can ask you in anatomy and the hypertensive bleed. Now I am changing the image to this. I want all of you to tell me the shape of the hemorrhage is biconvex. What is the shape of the hemorrhage? Biconvex. It is limited by, anyone? Limited by skull sutures. Limited by sutures. Patient clinically will show lucid interval due to rupture of middle meningeal artery. Which hemorrhage are we talking about? We are talking about extradural hemorrhage, also called as epidural hemorrhage. Okay. Quick question. We discussed this in DVT also. Any one of you can quickly revise. What is the management? We need to make a urgent burr hole or craniotomy with evacuation of hematoma. You need to do a urgent burr hole or craniotomy with evacuation of hematoma, because otherwise the patient will herniate. There will be a transtentorial herniation happening. We better do a urgent surgery here, which is a classic question in the exam. Okay, second image. I'll zoom in and I want you to answer. Now the shape of the blood clot is concavo-convex. Can also be written as a crescent. Concavo-convex crescent. Limited by, anyone, limited by dural folds. Cannot cross. Cannot cross midline. Cannot cross midline. Okay. Anyone? Due to rupture of bridging veins. Due to rupture of bridging veins. Commonly seen in old patients, shaken baby syndrome, or we might say alcoholics. But always remember this hemorrhage will be subdural hemorrhage. There are two possibilities in the exam. Either they will show you a subdural hemorrhage which is appearing white, then this is a acute subdural hemorrhage. Always remember for your exam, with time the density of the clot will reduce and become like CSF. With time, the density of the clot will reduce and it will become dark. So if in the exam they show you subdural just like the last NEET PG, but it appears dark, then you will label it as chronic subdural hemorrhage, which is there in your DVT workbook also. Then you will label it as chronic subdural hemorrhage. So this one is a acute subdural hemorrhage that I have shown you in the rapid revision book. Are you clear, beta? Okay, beta. I'm very happy with the answers, but I will keep a steady pace in the class. I will keep a steady pace in the class. Okay. Shaken baby. I will not increase more than this. I will not reduce more than this. My goal is to do a rapid review, but make sure that everybody is with me. Okay. So old people, shaken baby, you can have subdural. Okay, bacho. Now please tell me. Suppose they give you an image where the finding is in the CSF spaces. The blood, the hyperdensity is there in your sulcal spaces, in your cisterns. Then you will label it as subarachnoid hemorrhage. The question will mention worst headache of his life. It is usually due to rupture of berry aneurysm. Investigation of choice to look for a berry aneurysm in this patient will be investigation of choice to look for berry aneurysm in this patient will be a CT angiogram. CT angiogram. But if they ask you how will you manage this patient to prevent rebleed in this patient, I want all of you to understand, to prevent rebleed in this patient, you need to do a management endovascular procedure by intervention radiology, which is called as endovascular coiling, which is called as endovascular coiling, endovascular coiling. Okay. Subarachnoid hemorrhage will be seen as blood in the blood is in the sulcal spaces and other CSF spaces will appear hyperdense. This is how you will identify in the exam. Okay. So these are very, very important questions, very frequently asked. But suppose they change the image to this. Now we need to know, now the disease that you see here is this. There are three lines to remember. The disease that you see here appears hypodense. It is not like a hemorrhage, it is dark. It is shaped like a wedge. Conforms to a vascular territory called as middle cerebral artery. This is when you think of acute MCA territory infarct. Acute MCA territory infarct. This must be a main stem occlusion. This must be a main stem occlusion. Okay, bacha. Why direct question for all of you? Anyone can answer. If they write in the exam, patient has stroke, what is your investigation of choice? if they say patient has stroke, investigation of choice is NCCT. NCCT. Now I hope you can see this is within the brain parenchyma. This is not a subdural beta. It is not outside the brain. Brain itself is appearing more dark. This is a infarct. Investigation of choice, NCCT. Purpose of NCCT? To rule out hemorrhage. To rule out hemorrhage. A CT scan can show a brain infarct between 6 to 24 hours of onset. A CT scan can show us a brain infarct between 6 to 24 hours of onset. Okay, bachcho, now tell me. Now suppose they show you an infarct like this. Suppose you have an infarct like this on a CT scan. This means that this is a branch vessel occlusion. This means it is a branch vessel occlusion. Infarct is less than 1.5 centimeter. What do you call it? This is called as a lacunar infarct. This is called as a lacunar infarct. So both of them are possible in the exam. Either they will show you any hemorrhage or infarct in the NEET PG exam. It is very frequently repeated in your exams. Okay, next. Suppose they show you a NCCT in which your middle cerebral artery appears dense. Suppose they show you, okay, suppose they show you a NCCT in which your middle cerebral artery appears dense. Okay. If your middle cerebral artery appears dense, you will write it as the dense MCA sign. This tells you that there is a thrombus in your middle cerebral artery. Even before the infarct is visible, you can see the thrombus on a CT. So this is the earliest CT sign of hyperacute infarction. Okay. What is the earliest CT visible sign of hyperacute infarction? This is called as the hyperdense MCA sign. Hyperdense MCA sign. Are you able to do it? Okay, beta. In the previous CT, I saw some students were asking, so let me quickly recap for them. The white thing that you see here in the midline is your pineal gland. And the white things that you see within your lateral ventricle are the choroid plexuses. Okay. So it is physiological to see calcium in the pineal and calcium in the choroid plexus. Don't get confused in the real exam because of this. Okay. Clear? So I have just quickly reviewed for you the basic questions that you can expect. But suppose in the exam they write that the patient has a hypercoagulable state. Can you name any hypercoagulable state? A female patient on oral contraceptives. What is the risk? What is the risk? The risk is cerebral venous thrombosis. Suppose I tell you that this is the NCCT. What is the sign visible on this NCCT? Because of the hypercoagulable state, which could be pregnancy or oral contraceptives, your NCCT shows a, anyone tell me, delta sign. NCCT shows delta sign in cerebral venous thrombosis. Two more questions, beta. What is the CCT sign of cerebral venous thrombosis? What is the contra-CT sign of cerebral venous thrombosis? Then you will mark the answer as empty delta sign. Then you will mark the answer as empty delta sign. What is the investigation of choice for cerebral venous thrombosis? What is your IOC in these patients? If in clinics you are suspecting cerebral venous thrombosis, you will go with MR venography. Then the answer will be MR venogram. Okay, so we've seen normal anatomy of the brain, how to identify on the CT, different kind of brain hemorrhages, and how to identify on a and stroke on a CT scan. One point I want to write here is, if you have a lobar hematoma in the brain, Hypertension always causes, more commonly causes hemorrhage in the basal ganglia. If you see a lobar hematoma in a young patient, suspect underlying AV malformation. If you have a lobar hematoma in an old patient, what will you suspect? What will you suspect? You will suspect cerebral amyloid angiopathy. You will suspect cerebral amyloid angiopathy. Okay. So lobar hematoma in a young patient, think of underlying AV malformation. In an old patient, think of cerebral amyloid angiopathy. Now in this rapid revision program, I will show you another question. My goal is 100% strike rate. Whenever I am teaching, my goal is if you attend only this much, you should be able to get all the questions. So I also want you to have less of questioning mind, more of absorbing mind at this point. Because when you come for rapid review, if I tell you the why behind everything, it will take a lot of time. My goal is to cover everything in a quick manner. Okay, beta? Okay, बच्चों. I'll cover in sufficient depth. Okay? Okay, जितना मैं बताऊंगा उतना आएगा पेपर में. Anyone? If the patient is bedridden, because of this experience, I can tell you from last 25 years, beta. Patient is bedridden, sudden onset, breathlessness. Investigation of choice, CT pulmonary angiogram. Investigation of choice, CT pulmonary angiogram. Any one of you can answer, beta. What is the structure marked? Ascending aorta. What is the structure marked? Descending aorta. What is the structure marked? Main pulmonary artery. What is this structure? SVC. Okay. Now only thing I want you to see is this. Anyone can tell me what is the sign? What do you see? You can see a saddle shaped embolus in your pulmonary artery. This patient on CT pulmonary angiogram shows pulmonary thromboembolism. The patient has pulmonary thromboembolism. Screening test. What is the screening test for pulmonary embolism? D-dimer assay. What is the most common chest X-ray finding? Chest X-ray is usually normal in these patients. Chest X-ray is usually normal in these patients. Well done, beta, everyone. So one of the emergencies that I always expect is bedridden patient with breathlessness. Second is a patient with Marfan syndrome comes to you with chest pain. What do you see here? There is double lumen or aortic dissection involving which part? It appears to involve the ascending aorta. There is dissection in the aortic ascending part of aorta. This is your true lumen. The larger one which is not enhancing is the false lumen. Okay? Anyone? If the ascending aorta is involved, what type of dissection is this? It is called as Stanford type A dissection because the ascending aorta has dissection. Management. Stanford type A dissection should be managed by urgent surgery because there is a high risk of cardiac complications which can lead to sudden death. Okay. Same point here I will write here only. If it is Stanford type B, then what will you do? Stanford type B means only the descending aorta is dissected. Then the management will be medical management. Then the management will be medical management. Okay. Okay, let me just add a small page here to get the line here. Okay, so what is the investigation of choice for aortic dissection? Aortic dissection investigation of choice, CT angiography. CT angiography. If the patient is unstable, you do a bedside transesophageal echocardiogram. If the patient is unstable, we do a bedside transesophageal echocardiogram. Okay, बच्चों? Okay. Now, two lines about contrast material. What contrast material do we use in a CT scan? CT scan uses iodinated contrast. First line, always remember, iodinated contrast. What is the risk with iodinated contrast? Only two lines that I will highlight in the rapid revision. There is a risk of anaphylactoid reactions. Some patients may develop a non-IgE mediated anaphylactoid reaction for which adrenaline is the lifesaver. For which adrenaline will be the lifesaver drug. Any other risk with contrast material in CT? They very often asked. Always do a serum creatinine. You need to start with serum creatinine because they can cause nephropathy. How will you prevent contrast mediated nephropathy? How will you prevent contrast mediated nephropathy? The patient should be well hydrated. Patient should be well hydrated. What test you need to do before doing a CT scan, before doing a CCT? Always do a serum creatinine. Always look at serum creatinine before you do a CCT. Okay. These are very common questions asked in your exams, and I feel once you are able to do it, we can do it. Okay. Done? Okay. So these are the common things that we have expect out of the initial part of the class. Now before we go on, I just want to quickly recap for you. So far we have seen the normal anatomy on a CT scan of the brain, different types of brain hemorrhages, strokes, pulmonary embolism, aortic dissection. These are usually, one or two questions in NEET PG are definitely asked from this topic that we have already seen. If I have to make a paper, I always would put a EDH, SDH, SAH. एक तो इनमें से आएगा, एक stroke होगा. Okay, very important. One normal anatomy question. So we have already covered one or two questions that will be there in your exam. Out of my full confidence, I am able to tell you. Next, we need to know a MRI. In your exam, it will be critical to identify the image in the exam. Okay. So is this a CT scan or a MRI? Always remember, I will make a small table here only. Always remember two things. Okay. I'm just removing some things to create some space. Always remember two basic ideas, one of CT scan, one of MRI. Okay. On a CT scan, the structure appearance will be based on Hounsfield scale. Hounsfield scale plus 1000 will be calcium or bone. They will appear very white. 0 will be water. Minus 1000 will be air. So we know on a CT scan air will be black, bone will be white. Fat will be dark, it will be at around minus 100, minus 50 to minus 100 fat. 20 to 40 will be your brain parenchyma. Plus 60 to 70 will be your hemorrhage. So always remember on a CT scan, the structures that we will see will be based on their Hounsfield value. Minus 50 to minus 100 will be fat, brain hemorrhage, or we can simply say blood clot. Okay, if that is more easy, we can write here the blood clot will be in the brain 60 to 70. That is why brain hemorrhage was more white than the surrounding parenchyma. So if I now take a moment and I highlight this point for you, this is called as Hounsfield scale. On a MRI, the basis will be the appearance on T1 and T2 weighted image. I am going to make a chart here only. Okay, or maybe we can add a page for your later on revision. Just give me 1 second to add a page. Okay, on MRI it will be very simple. They will ask you how will be the appearance on T1 weighted image, T2 weighted image. You just need to fill up the blanks. CSF. CSF will be dark on T1, white on T2 weighted image. What about fat? Fat will be white on T1, less white on T2 weighted image. Okay. Anyone can now answer, what about the cortex of the bone? Calcium. Dark on both T1 and T2 weighted image. Bone, cortex and calcium on MRI are dark. On CT they will be white. What about air? Dark on both T1 and T2 weighted image. Fibrous tissues like tendon, ligament, always dark. Dark on both T1 and T2 weighted image. Hemosiderin, flowing blood, are also dark on both T1 and T2 weighted image. Okay, so I'm zooming out so that you can simply see it here. So even if you're not writing, it is okay. You will get this sheet to quickly revise later on. This is what we use in MRI. So on a CT scan we use Hounsfield scale. On MRI we use the table that is defining T1 and T2 weighted appearance. CSF will be dark on T1, white on T2. Fat will be white on both. Cortex is better to listen to me more better because notes you will have with me. I will just, whatever I'm writing, I will upload the same slide. I'm writing, that is why you will see my writing. I'm trying my best writing here. CSF, fat, cortex, air, fibrous tissue, hemosiderin, flowing blood. This is what you need to remember. Regarding gray and white matter, I will show you with a image. So I want all of you to see this image with me. This is the first image in MRI that you need to be thorough at. The arrow that I'm marking is your scalp fat. This is your scalp fat. The fat in our scalp is appearing white because this is a MRI image. And I want all of you to now notice this dark area is the bone. Can you see this? This is your bone. So this must be MRI. In the ventricle you have CSF. CSF is appearing dark. In the ventricle you can see the CSF which is appearing dark. The brain cortex is your gray matter which has the neurons. Below the cortex you have the white matter where you have the axons which are covered by myelin. Okay, so this is what is called as white matter. So I want you to understand, in this image I will write down what you need to know. You just need to listen to me right now, and you can take the notes later on. This notes will be available for you, don't worry. In this image the CSF is, tell me, dark. Answering on the chat box will be more valuable right now because it is a quick review for you. And the white matter appears more white than the gray matter. White matter, just like the normal anatomy, is more white than the gray matter. These are the properties of a T1 weighted MRI image. The answer in the exam will be T1 weighted MRI image. Okay. The second possibility in the exam is this. Can you all now easily see the bone is appearing dark? The scalp fat is white. This must be a MRI. What about CSF? CSF appears white. The CSF in the ventricle appear white. What is the relationship of gray matter and white matter? Now I will zoom in and show you. As compared to the gray matter, the white matter is darker. As compared to the gray matter, the white matter is appearing darker. What do you think? These are properties of a T2 weighted image. These are properties of a T2 weighted image. T2 weighted image is best suited for pathology. T1 weighted is best suited for anatomy. T2 weighted, pathology. Okay, so once you're clear with this, the only problem is if the pathology is periventricular, if you have a disease which is near the ventricle, sometimes it is difficult to see on a T2 weighted image. So what we do is, suppose I take a T2 weighted image And using a MRI technique, I suppress the signal from the CSF. Suppose you take a T2 weighted image to see the periventricular pathology, you will suppress the signal from the CSF. So what will happen? The CSF, because the signal is suppressed, will appear dark. But the white matter, because it is primarily a T2 weighted image, white matter will appear darker than the gray matter. So this is how you differentiate. If the white matter is dark, CSF is dark, this is not T1. This is going to be called as FLAIR image. Best for periventricular pathology. It can even show you periventricular pathology. Do we need to know the full form? No need. But just for your sake of completion, it is called as fluid attenuated inversion recovery sequence. Just for your understanding, I am quickly saying it is called as fluid attenuated inversion recovery sequence. Okay. Now some students are getting confused. Most of the diseases, if you have a disease, you will have edema. Most of the diseases, if you have a disease, they will have edema. So edema will be dark on T1 because of the fluid in the tissue, white on T2 weighted image. Most of the diseases will be dark on T1, white on T2 because of the presence of edema. Can anybody tell me any exception? The exception to the rule is a melanoma because of melanin content. It will be reverse. It will be white on T1 weighted image. It will be white on T1 weighted image. If the tissue or the tumor has a magnetic substance, the appearance will reverse. Otherwise, most of the pathologies will be white on T2 weighted image. If they ask you which tumor is exception, what will you mark? You will mark the answer as melanoma. You will mark the answer as melanoma. Okay? Are you able to do it, beta? Okay, bacho. Okay. So far I have shown you the axial MRI images T1, T2 FLAIR and their questions that can be asked in the exam. Now I want to quickly recap with you a sagittal image. I want to revise with you a sagittal MRI image. Okay? Anyone? Why we are able to see a sagittal image? Because MRI is a true multiplanar investigation. MRI is a true multiplanar investigation. It can take sections in any plane of the body. Any one of you can very fast answer MRI. Okay, any contraindication you are aware of? Always remember intraocular metallic foreign body is the most important question. Intraocular metallic foreign body is an absolute contraindication to MRI which can anytime be asked in the exam. Others are also important like metallic implants, but one best answer always look for intraocular metallic foreign body. Okay. Okay, beta. I will label a structure as 1. Can you identify the structure marked as 1? 1 is your corpus callosum. 1 is your corpus callosum. Okay. What is the structure marked as 2? What is the structure marked as 2? 2 is your cingulate gyrus. 2 is your cingulate gyrus. What is the structure marked as 3? Anyone? 3 is your fornix. 3 is your fornix. So below the corpus callosum, the structure that you see here in the midline is a very important question. This is your fornix. Any one of you can answer the structure marked as 4. What is the structure marked as 4? Thalamus. Okay, the 4 is thalamus. Very important questions now will be labeled and you have to quickly answer one by one. I will take a thin pen for your revision. Number 5, number 6, number 7. Any of them can be asked in the exam. What is 5, 6 and 7? 5 is your midbrain. Anyone? 6 is your pons. 7 is your medulla. 7 is your medulla. What about the structure marked as 8? Okay, this is the previous NEET PG question. Structure marked as 8. The structure marked as 8 is your cerebellar vermis, because in the midline of the cerebellum you have the vermis, that is the cerebellar vermis. Now I will ask you a few questions which are going to be slightly tough. I will try to put a mark there. Number 9. Can you see between the pons and the cerebellum there is a CSF space? The pons and cerebellum, in between them the CSF space is called as the fourth ventricle. That is your fourth ventricle. Okay beta? Okay, one tough question now. Can you identify a cigar shaped structure posterior to the thalamus? Can you identify a cigar shaped structure posterior to the thalamus that I am labeling as number 10? Okay, number 10. Anyone try the number 10? Yes. So this number 10 is your pineal gland. So I have shown you pineal on a CT as well as pineal on the MRI. Okay. Okay, beta. So whenever you look at the sagittal section, these are the common questions that we expect in the exam. But sometimes they go for slightly tougher questions which I have to identify for you. Identify the structure marked by the arrow. Identify the structure marked by the arrow and in which condition it is affected. This is your mammillary body, affected in Wernicke's encephalopathy. In which condition, which vitamin deficiency is Wernicke's encephalopathy? Thiamine deficiency seen in alcoholics with ataxia, confusion, ophthalmoplegia. This is your mammillary body that I want you to keep in mind. Anterior to the mammillary body, I want you to identify the structure marked with the blue colored arrow. Can you identify now? Anterior to the mammillary body, this is where you have your optic chiasma. Optic chiasma. Okay. Now I will label it for you with a different color now. Let's see if we have more colors with us. Okay. So what I'll do is I'll use a red colored arrow for this organ. Below the optic chiasma, above the sella, this is your pituitary gland. Pituitary gland has two parts. The brighter part is the posterior pituitary. This is your pituitary gland. So pituitary gland appears to have two parts. The brighter part is the pituitary bright spot. So I will write it down here. Posterior pituitary appears as a bright spot. Why? Due to presence of ADH. Due to presence of ADH or vasopressin. That is why absence of this will be seen in diabetes insipidus. So posterior pituitary will be seen as a bright spot. Everybody look at the screen. This bright area is your posterior pituitary. So it is because of presence of ADH. It is because of presence of ADH. Okay, beta. Now, identify the MRI technique and the logic behind it. This MRI image shows a bright area. You don't see the differentiation of T1 and T2 weighted image. You don't see the differentiation of T1 and T2. Okay. Before I go on, posterior pituitary is physiologically bright. It is naturally bright. Okay. In normal MRI, it is bright. Okay. So you don't see the gray white matter differentiation in this image. This is a diffusion weighted MRI based on Diffusion weighted MRI is based on particle motion. If the particle motion is affected, that area appears bright. If the particle motion is affected, that area appears bright. Now why is this area bright? Because this is the brain infarct. Brain infarct can be earliest seen on DWI. How early? 3 to 30 minutes of onset. As early as 3 to 30 minutes of onset, you can see a bright area which is your infarct. Why the particle motion is not happening? Because the ATP reduction in ischemia is blocking the sodium potassium ATPase. Because the ATP is not there, that is why the sodium potassium ATPase is not working. Okay, this is again a possible question in your exam. Brain infarct is earliest seen on diffusion weighted MRI. Okay, identify the next image. If they ask you to identify this image, this is a MRCP. This is a magnetic resonance cholangiopancreatography, MRCP. Anyone can answer, beta. MRCP. Okay, anyone can answer. Give me just 1 second to get the colors. Okay. On the MRCP, the ducts are appearing white because it is a technique called as heavy T2 weighted image. We are using high T2 weighting to make the fluid appear white without using any contrast material. No dye has been used, no radiation. It is a non-invasive test. Can you answer this? No dye, heavy T2 weighted image, no radiation. If I ask you to label the anatomy, can you identify the structure marked? Can you identify the structure marked? Yes, this is your pancreatic duct. What about this one? Common bile duct. Common bile duct. So if they show you cystic dilatation of CBD, that will be choledochal cyst. If they show you a filling defect, that will be a choledocholithiasis. So identify the investigation. This is a non-invasive MRCP. Okay, beta. If they ask you to differentiate from this one, then if they show you a endoscope and you see the bile duct and pancreatic duct, then you will mark it as ERCP. Invasive. Uses side viewing endoscope. Uses a side viewing endoscope. Radiation plus. Dye plus. It uses contrast material, it uses X-rays, it is an invasive test. It can have both diagnostic and therapeutic uses. It can have therapeutic uses also, while MRCP was only diagnostic. MRCP was only diagnostic. It uses a side viewing endoscope which is different from upper GI endoscopy. Okay, let us revise another slide. Identify the investigation. In this image, the bones are appearing dark. The fat in the brain orbit is appearing white. Bone is dark, fat is white. This must be MRI, but it only shows the vessels. It is a MR angiogram. On this MR angiogram of the brain, I want you to identify the structure marked as 1. I want you to identify the structure marked as 1. What is the structure marked as 1? Vertebral artery. This is your vertebral artery. What is the structure marked as 2? Anyone? What is the structure marked as 2? Then you need to remember the basilar artery. Okay. The structure that I'm marking now is your internal carotid artery. Internal carotid artery is giving rise to a branch which is going towards the Sylvian fissure. This is your middle cerebral artery. and in the midline, it is giving a branch called as the anterior cerebral artery. So are you able to identify the basic anatomies? So this is your anterior cerebral artery, this is your middle cerebral artery. Okay, identify the investigation, MR angiogram. Okay, quick, MR angiogram is preferred for screening of cerebral aneurysms. Because of lack of radiation exposure, it is preferred as a screening test in high-risk individuals for cerebral aneurysm. Which people, can you think of a condition? So it is used in patients with autosomal dominant polycystic kidney disease. It is used in autosomal dominant PCKD as screening for cerebral aneurysms. Okay, before we go on, I just wanted to ask you a few questions. In which condition do we see puff of smoke appearance on an angiogram? In brain, in which condition due to collateral formation you see puff of smoke appearance on an angiogram? Then you always remember the Moya-Moya disease. In which condition do we see the puff of smoke appearance? Moya-Moya disease. Okay. Can you think of a disease in which the child, a newborn, will have hydrocephalus, heart failure? Keywords: newborn. And MRI shows a dilated vein of Galen. Can you think of a condition in which there is hydrocephalus, heart failure, newborn, MRI shows a dilated midline vascular structure? That is called as vein of Galen malformation. What is vein of Galen malformation? It is a AV fistula in the median prosencephalic vein. It is a AV fistula in the median prosencephalic vein leading to a large head as well as congenital heart failure. Okay, can you keep this in mind? Very important questions. Okay, now sometimes they change the image to this. I'll just keep one image here of the knee joint. The bone marrow, because of the inherent fat in the bone marrow, is appearing white. But if you look closely at the cortex of the bone, the cortex is appearing dark. The cortex is dark, bone marrow is white. Okay, is this a CT scan or a MRI? This is your patella, this is your femur, this is your tibia. What do you think? This is a sagittal MRI of the knee joint. This is a sagittal MRI of the knee joint. Two important questions. Identify the structure labeled as A, structure labeled as B. A is a ligament connecting the femur to the anterior part of the tibia. B is a ligament connecting the femur to the posterior part of the tibia. So both of them are ligaments. So A is your anterior cruciate ligament. B is your posterior cruciate ligament. Some of you are getting confused. The dark area that you see here is your patellar tendon. Okay. So patellar tendon will be seen inserted on the tibial tuberosity here. So then you can differentiate. That is the patellar tendon. Are you clear, beta? Okay. So this is how you see a MRI. Always remember these few keywords. Bone cortex is best seen on CT. Bone marrow, cartilage, tendon, ligament, soft tissue, always MRI. Muscle, MRI. In your musculoskeletal system, only the bone cortex is CT, but bone marrow, also any cartilage lesion, tendon, ligament, muscle, always do a MRI. This is one of the reasons if they write in your exam stress fracture, where you have a bone marrow edema visible on the site of injury, IOC, MRI. Because MRI will be able to pick up stress fracture better than a CT, because on the site of injury you will have bone marrow edema. This is very important question, multiple times repeated in the exam. Acute osteomyelitis, investigation of choice is MRI. Why? Because it can show us bone marrow edema within 24 hours of onset. Because you can see the bone marrow edema within 24 hours of onset. Okay, beta. Side by side, I want you to tell me about the contrast material in MRI. Only few lines I will tell you. Contrast material used in MRI is gadolinium. Okay. Remember two lines. Contraindicated in pregnancy. Contraindicated in pregnancy. Contraindicated in CRF. Why? Because it accumulates in the body, in our body parenchyma, in our tissues, in CRF, it causes nephrogenic systemic fibrosis. It should not be used in renal failure because of risk of nephrogenic systemic fibrosis. Okay, so iodinated contrast should not be used in renal failure because of risk of, anyone remembers, nephropathy. While MRI, the gadolinium is not used for CRF patients because of risk of, anyone remembers, risk of nephrogenic systemic fibrosis, because of the risk of nephrogenic systemic fibrosis. Okay, bachcho. Okay. Now we'll quickly look at some diseases. In this FLAIR MRI image, you can see the disease is appearing like fingers. Can you see there are finger-like areas of white matter abnormality appearing perpendicular to the ventricle? These finger-like areas appearing perpendicular to the ventricle are called as Dawson's fingers. Can anybody tell me, revise, which condition? Multiple sclerosis, which is a relapsing, remitting, demyelinating neurological disorder. Which MRI criteria is used in multiple sclerosis? MRI criteria used in multiple sclerosis is McDonald's criteria. McDonald's criteria. And I want you to see these images to understand the concept. Suppose you see on a T2 weighted image multiple lesions. Multiple white matter lesions are visible on a T2 weighted image. But when we do a contrast MRI, only few of them are enhancing. Why all are not enhancing? Because they must be old lesions. Only the new acutely inflamed lesions are enhancing. This is called as, anyone can give me the note here, dissemination in time. Also notice the disease not only is in the central nervous system, it is not only in the brain, it is also seen in the spinal cord. It is widespread. It is widespread. You can see a cord lesion also. This is called as dissemination in time and space. These are typical features of multiple sclerosis on a MRI. Dissemination in time and space. Okay, bachcho. Identify the problem and the cause. Always remember, if you see a ring enhancing lesion in the brain, if you see a ring enhancing lesion in the brain, it is usually a infection. It is usually a infection. I will give you a very simple approach to it. If the infection has a scolex inside, if the infection has a scolex inside, it must be NCC. If the infection is conglomerate with lipid peak on MR spectroscopy, if the infection is conglomerate with a lipid peak on spectroscopy, you will mark it as tuberculoma. If the infection is present in a HIV positive patient, then it is toxoplasmosis. Okay. However, if there is an infection in a patient who has a reservoir of infection like CSOM or sinusitis, then we are probably dealing with a brain abscess. Confirmation will be abscess is bright on diffusion weighted MRI. Abscess is bright on diffusion weighted MRI because it will have thick viscous pus inside which will not have any particle motion. This is an approach to the ring enhancing lesions in the brain. If you see a scolex, then it is NCC, conglomerate, tuberculoma, HIV patient, toxoplasma, abscess, bright, diffusion. Okay, keep it in mind. This is a contrast MRI and this ring-like enhancement is seen due to increased vascularity which happens in inflammation. Okay. Are you able to do it? Okay, bacho. Next. Okay, bacha. Based on what we have learned, I want all of you to try and answer this one. What do you see in the image provided to you? In the image provided to you, okay beta, so let me come back to you so that you know if you had any issue we can do it again. Now please see. So suppose on the MRI they show you cystic lesions, multiple cystic lesions which have visible scolex. Can you see the visible scolex? Yes. If you see the visible scolex, then it is neurocysticercosis. Second thing we need to remember is this is the viable stage of NCC. Okay. Viable stage of NCC is called as the vesicular stage. Okay. And always remember symptoms and edema is usually seen more in the degenerating phase. Symptoms and edema happens when you come to the degenerating stage. Can you name the degenerating stage, which is also called as the colloidal stage? So if you see the cyst with a scolex, that is vesicular stage. If they ask you maximum edema, maximum symptoms, colloidal stage. Colloidal stage. Okay, try this one. Suppose I give you a X-ray of the bones, X-ray of your pelvis, and you see calcification like this in the muscles. What is the pattern? Rice grain calcification. If they show you rice grain calcification in the muscles like this, anyone? Then this is your myocystic sarcosis. In the muscles, neurocysticercosis, then it becomes myocystic because it is in the muscle. It takes the shape of the muscle spindle and looks like rice grain appearance. Okay, beta, now try this one. Okay, one line here. When the parasite is dead, it becomes the nodular calcified stage in the brain. This is the stage where the edema becomes nil. So there will be no edema around the parasite. If they ask you which stage of NCC has no edema, mark it as nodular calcified because the parasite is already dead. Okay, bacho. Suppose they show you ring lesions which are conglomerate. Ring lesions which are conglomerate, we think of tuberculomas. tuberculomas. Okay, and also remember these tubercular lesions, if they are touching the meninges, they can, if they are touching the meninges like this, they can spread the inflammation onto the meninges. So if the infection spreads to meninges, it is called as tubercular meningitis. Always remember two lines about tubercular meningitis. Anyone? Basal exudates. The inflammatory material will be seen in the base of the brain. Any other two lines that you can remember about tubercular meningitis? Anyone? Can cause infarcts due to tubercular endarteritis. Can cause hydrocephalus due to obstruction of CSF pathway. So hydrocephalus, infarcts, basal exudates. Always mark the answer as tubercular meningitis. Okay. So conglomerate ring lesions are tubercular. Tuberculomas on MR spectroscopy show. Anyone? Lipid peak. Tuberculomas on MR spectroscopy show lipid peak. These are common questions that I am expecting out of the infections. Now, very quick question. Is this an infection? Is this an infection? No. This is a solid tumor. This is a contrast MRI showing a solid enhancing tumor adherent to the meninges, attached to the falx. This must be a meningioma. Okay. Name the sign. It shows the dural tail sign on MRI. What will you see on your histopathology? Histopathology will show psammoma bodies. Associations. It is known to be associated with NF2. Any other association? Known to be associated with prior radiation exposure to the skull. Associations, NF2, radiation exposure to the skull. This is how you identify meningioma in the exam. Okay, bachcho. Try to identify this patient. This is your petrous temporal bone. It is appearing dark because this is a contrast MRI. MRI, the bone will be dark. This is your pons, cerebellum. Patient has sensory neural hearing loss. Sensory neural hearing loss. There is a solid looking tumor at the CP angle. Solid looking tumor at the CP angle, which appears to extend like a ice cream cone into the internal auditory canal. Name the tumor and the association. Appearance, ice cream cone appearance on contrast MRI. Question will say patient will have deafness. What is the tumor? Vestibular schwannoma. What is the tumor? Vestibular schwannoma. Association, NF2. Microscopy will show the Verroque bodies. Microscopy will show the Verroque bodies. This is Antony A, Antony B zones, NF2 association. Okay. Okay. Next in the exam, they might ask you a tumor which is sitting in this contrast MRI. Can you see a tumor in the center in the area of the sella turcica, which is appearing like this? Can you see the tumor? It is appearing like a snowman. In the center, it is indented by the diaphragma sellae, giving rise to a snowman appearance. Figure of 8 appearance. Cottage loaf appearance. This is a pituitary macroadenoma. Why it is pituitary macroadenoma? Because it is more than 10 millimeter in size. Because of this large size, it is going to go up and it is going to compress the optic chiasma sitting over the top. So the patient will typically come to you with the characteristic visual field defect. What visual field defect do you expect? We expect the compression of optic chiasma. So that will lead to bitemporal hemianopia because there will be compression of optic chiasma. This is how they will integrate the question and ask you in the exam. Are you able to do it? So the question will usually say a visual field defect. Microadenomas on the other hand are less than 10 millimeter in size. They are in millimeters. So they will come with hormonal effect, not with mass effect. Macroadenoma will come with mass effect because of the larger size. Okay, bachcho. So once you are able to do it, I want you to solve this question also. Suppose they say a child has a calcified tumor in the suprasellar cistern. Remember in the anatomy I taught you a star-shaped area in the center? Suprasellar cistern calcified tumor in a child. Always think of a Rathke's pouch remnant tumor called as craniopharyngioma. Key word will be, patient will be a child and the location will be suprasellar and the tumor will be calcified. On pathology, this tumor will be solid and cystic both. It will have solid area, cystic area. But can you tell me what will you find in the cysts? These cysts will have motor oil-like content. These cysts will have motor oil-like content in a craniopharyngioma. Okay. Suppose they show you a tumor which is appearing more heterogeneous with solid and necrotic tissues crossing the midline. Then we think of a malignant primary brain tumor of the brain called as glioblastoma. Appearance like a butterfly. Prognosis poor. Prognosis will be poor. Are you able to do it now? Classic questions in the exam. Rapid progression and poor prognosis. The tumor will be glioblastoma. Okay. Suppose they tell you a child has a face like this, comes to you with epilepsy or seizure disorder. Face shows a port wine stain nevus. And in the eye, the child has congenital glaucoma. Association congenital glaucoma. What do you suspect? We look at the skull X-ray. In the skull X-ray of the child, what is the finding? There is calcium in the brain gyri which is giving rise to a tram track like appearance. So there is a tram track like appearance in the skull X-ray which on a CT scan is seen as gyral calcification. There is calcification of your gyri. Put it all together. If you put it all together, the answer will be Sturge-Weber syndrome. Is it an inherited disorder? It is not inherited. It is anyone? Sporadic disorder. X-ray skull will show tram track appearance. And if you also notice, on the CT, half of the brain is atrophied. The word that they will write in the paper will be hemiatrophy. So can you quickly recap with me? The keywords will be child with epilepsy, port wine stain, gyral calcification, tram track appearance, hemiatrophy, glaucoma. Keep in mind the answer will be Sturge-Weber syndrome. Okay, the answer will be Sturge-Weber syndrome. If the child looks like this, these are what are called as adenoma sebaceum. Okay, adenoma sebaceum are associated with tuberous sclerosis, which will have epilepsy along with low IQ. Tuberous sclerosis, inherited in a autosomal dominant fashion. It is a autosomal dominant condition. How will you identify on a CT? On the CT scan, the brain will show calcification. The calcification will be seen in the walls of the ventricle. This is called as subependymal calcific nodules. Subependymal calcification is typical of tuberous sclerosis hamartomas. Can you tell me what do you expect, which brain tumor can you expect in this condition? Which brain tumor can happen in tuberous sclerosis? The brain tumor is called as SEGA. What is SEGA? Subependymal giant cell astrocytoma. What do you expect in his heart? Which cardiac tumor can happen in this condition? Cardiac rhabdomyoma. What can happen in his lung? The lungs can have lymphangiomyomatosis, cystic changes in the lung due to lymphangiomyomatosis of your lungs. Okay, so these are classic associations that can be asked about tuberous sclerosis. Okay, can you tell me, in the same patient, if you look at his kidneys, both the kidneys appear large with multiple dark colored tumors. Multiple dark tumors. What are these? So these are bilateral renal angiomyolipomas. Angiomyolipomas are fat-containing renal tumors seen in tuberous sclerosis. Then you will think of tuberous sclerosis. Okay. Next image, we need to understand the lines that I'm now drawing are your tentorium. Above the tentorium, you have the cerebrum. Below the tentorium, you have the cerebellum. I want all of you to see in the cerebellum, are you able to identify a tumor? Yes. What is the appearance of the tumor? It appears cystic. Is it purely cystic? No, when we look closely, it has a nodule inside. Okay, so I'm going to summarize. This cerebellar tumor has a cystic lesion with a solid mural nodule. Such an appearance is very typical of a tumor called as hemangioblastoma. So a very classic question, in which condition do we see cerebellar hemangioblastomas? They are known to be associated with autosomal dominant von Hippel-Lindau disease. They are known to be associated with von Hippel-Lindau disease. Also remember, VHL is also associated with this pathological image. Can you identify now? Clear cell RCC. Clear cell RCC. Which brain tumor seen in VHL? Hemangioblastoma. Which location? Cerebellum. Appearance? Cystic with mural nodule. Cystic with mural nodule. Can you do it now? Okay. Which ENT neoplasm is associated with VHL? Endolymphatic sac tumor. Which ENT tumor is associated with VHL? Endolymphatic sac tumor. Okay, bachcho, now try and answer this one. I want all of you to look at this image and tell me, are you able to see enlargement? Can you see enlargement of the optic nerve? This is a optic glioma, which is nothing but a pilocytic astrocytoma of the optic pathway. Pilocytic astrocytoma of the optic pathway. Association NF1. Associated with NF1, neurofibromatosis type 1, chromosome 17. NF1, always remember, also associated with bony lesions. It can have bony defects like the characteristic bony defect is this one. What is this? Bare orbit appearance. Due to there is abnormal formation of the sphenoid. There is sphenoid is not properly formed. There is sphenoidal dysplasia. What other bony defects can be seen in NF1? Tibial pseudoarthrosis. Any other? Ribbon-like ribs. Scoliosis. So NF1 can have tibial pseudoarthrosis, ribbon-like ribs, scoliosis. In skin, NF1 in the skin will show Café-Ullard spots. NF1 in the skin will have Café-Ullard spots. So very quickly we have covered the some common tumors, infections and multiple sclerosis which can be asked as a question in your exam. Okay, comfortable so far? Okay, so now what I'll do is I will do a quick recap of the chest imaging. Okay, so we have looked at the brain imaging with the basics and we have taken less time because I'm trying to do a quick review for you so that you are in the right place. Are you ready? Okay, can we start? Okay, done. Okay, so let us look at the normal chest x-ray first. Normal chest x-ray first. The first image I want you to do is we will label the anatomy. This is a chest x-ray PA view. This is a chest x-ray PA view. Okay, chest x-ray PA view. Okay, beta, we are totally live with you. Yes. Okay, are you able to hear me? Yes, beta. Okay, now on the chest x-ray PA view, I am labeling the first structure as 1. Can anybody label the 1 for me? This is your trachea. I will label it now 1. Okay, this is your trachea. Always try to see is the trachea pulled, push or central. Collapse will cause pulling of the trachea. The pleural effusion or pneumothorax will push. Consolidation will be central. Okay, bacho. Now try and answer this one. Identify the structure marked as 2. Below 2 I am putting 3. Okay, bacho. Identify 2 and 3. 2 is your aortic knuckle. 3 is your pulmonary bay. 3 is your pulmonary bay. I want all of you to identify the structure marked as number 4. Number 4. Anyone? So number 4, what you see at number 4 is your hilum. On X-ray, hilum is mainly made up of. It is mainly made up of pulmonary artery and upper lobe veins. Always remember, not by the lower lobe veins. Hilum is made up of pulmonary artery and upper lobe veins. These are your hilum. Okay, bacho. Then if you look at the left cardiac border, always keep in mind this small bulge here which is due to left auricle. The small bulge is because of the left auricle. If there is rheumatic heart disease, this auricle will bulge. Below it, can you see the line? This entire border is by the left ventricle. Okay, so this entire is your left ventricular border. On the right side, the cardiac borders are made up of right atrium small part by IVC, small part by SVC. Right cardiac border is formed by right atrium, superior vena cava, inferior vena cava. Now the only questions that are now left are these. Let's see if any one of you can answer. How do you measure the cardiac size on a X-ray? To assess the cardiac size, what do you do? Anyone? We measure the cardiothoracic ratio. You measure the cardiothoracic ratio. Anyone? Cardiothoracic ratio more than 0.5 in an adult means cardiomegaly. In an infant, 0.6. In an infant, 0.6. Okay, bacho? Okay. Second thing, sometimes they do is they ask you to identify the ribs. Always look at the rib from posterior to anterior. Start at the spine, then go anteriorly. I will just take a small second here to just label it for you. Can you see better this? Can you see? This is the posterior part of the first rib. Posterior part is more horizontal. Anterior part is more vertical. This is your first rib. Now please see the second rib. I'm painting it for you. This is the horizontal part, the posterior part of the second rib. This is the anterior part of the second rib. Many children in the exam, because I see some of you are thinking, sir, please explain anything, but my goal is rapid review, but I want to tell you what will be asked in the exam. Everything will be from the session in the exam. They will ask you to label the rib. Can you see the first rib? Can you see the second rib? I will show you the third rib also now. Okay, just have some patience for the third rib. Can you see now? So the entire idea in the ribs is the posterior part is more horizontal, the anterior part is more vertical. I will just remove the marking so that you can see later on easily. Okay. Now can you see? Posterior part is more horizontal, anterior part is more vertical. So how do we actually label the ribs in our own clinical life? Is we only see the posterior part first. I want you to see the posterior part with me. Okay, I'll just take a pen. 1, 2, 3, 4, 5, 6. Can you see I'm only looking at the horizontal part? 7, 8. This is how you count the rib easily. You don't look at the anterior part, just see the posterior part and count the ribs. Up to 0.6 is normal in an infant. Above 0.6 will be cardiomegaly. So how do you diagnose cardiomegaly? Above 0.5 in an adult, Gulafsha is asking. So and above 0.6 in an infant. Are you now clear, beta? This is the cardiothoracic ratio. So they might ask you to look at the ribs, lung parenchyma, or the bony cage. I will label the bony cage also. This is your clavicle. This is the scapula which is visible. You can see the scapula as well. This video will be recorded also, and the recorded video will be uploaded with you, and the notes will also, the whatever I'm writing will also be uploaded for you. Okay, bachcho. Because I know I want to make it more high yield. So that is why, I'm not just telling you 5, 6 things. I'm trying to do the complete radiology review for you. Okay, beta? This is the first rib, beta. Now are you clear, beta? This is the second rib. Okay, bacha? Okay, beta. Next question. Anyone can answer. Now in the next image, I want you to see, okay, I want you to see there is a opacity which is obscuring the CP angle. The CP angle is not visible. There is a opacity, and the diaphragm is also obscured. Diaphragm is obscured. Superior border of the opacity has a meniscus-like appearance. Superior border of the opacity has a meniscus-like appearance. This appearance is called as the meniscus sign, or we call it Ellis curve. Name the condition. Then the answer will be pleural effusion. For pleural effusion to be visible, On a PA view, we need 150 to 200 ml of fluid. But if you do a lateral decubitus view of the same side, if you do a lateral decubitus view, it can see even 15 to 25 ml of pleural fluid. And if you do an ultrasound, which is now considered the investigation of choice for pleural effusion, you can even see less than 10 ml of fluid, and also you can do a guided tap. You can do a ultrasound guided tap. So ultrasound is the investigation of choice for pleural effusion. Best X-ray will be lateral decubitus view. Best X-ray will be lateral decubitus view. Okay, bachcho? Okay. Now try and answer this one. If you see a X-ray in your exam, a chest X-ray in your exam, where the CP angle is obscured, if the CP angle is obscured by a pathology, that means it must be in the pleura. But the fluid is not spreading over the diaphragm. It is localized along the chest wall. If you see the fluid is more localized along the chest wall, it looks like a letter D. It is more localized along the chest wall, then you call it loculated effusion, which could be because of pus. So then the answer will be empyema, or it could be due to blood. Then we call it hemothorax. What is the diagnosis? Then this is a loculated effusion. Then we will mark it as loculated effusion. Most likely cause will be empyema. It will not be spreading over the diaphragm like a routine pleural effusion. It will be more localized because of the thick viscous nature of the pus. Okay, next question. Anytime they say patient has blunt abdominal trauma. Suppose they say in the exam patient has blunt abdominal trauma, what is the first investigation to be done? First investigation to be done will be FAST. FAST is focused assessment with sonography in trauma. What is FAST? Focused assessment with sonography in trauma. Okay, bacho, anyone can answer. Okay, let us try to zoom in with the image. Okay, purpose of FAST is to look for hemoperitoneum. Purpose of FAST is to look for hemoperitoneum. If there is hemoperitoneum, it indicates presence of solid organ injury. If there is hemoperitoneum, it is indirectly telling you that there is solid organ injury. Okay, bacho, quick question. Let's see if you can answer. If you also evaluate the thorax, then it is called as extended FAST. Then it is called as extended FAST. Okay, E means extended FAST. Previous question, you can answer it in the exam. FAST is good to pick up solid organ injury, but it can miss hollow viscous injuries, mesenteric trauma, retroperitoneal trauma, and diaphragmatic rupture. So sometimes they may ask you, what is the drawback of doing a FAST? It can miss hollow viscous injury, mesenteric injury, retroperitoneal injury, or a diaphragmatic injury. Okay. So how will they ask you in the exam? They will show you an image. This is your liver, this is your right kidney. Between liver and kidney, you should not see anything black. If you see something black between liver and kidney, that means there is fluid in the Morison's pouch. That means there is blood in the Morison's pouch. This will be called as Like some of you were already answering fast positive. Then we call it fast positive. Okay. Quick question. If the fast is positive, that means there is hemoperitoneum and the patient is stable. What will you do? If the fast is positive, the patient is stable, you will go for a CCT as the investigation of choice. Then you will go for CCT as the investigation of choice. If the fast is positive and the patient is unstable, fast positive patient is unstable is an indication for exploratory laparotomy. Then you will do a exploratory laparotomy. Whenever we do fast, we do a M mode ultrasound of the thorax. In the M mode ultrasound of the thorax, can you now tell me, you can see these black white lines with some dots. This is the seashore sign. What is your interpretation on this M mode ultrasound? Seashore sign is the normal appearance. You have to differentiate on M mode if they show you appearance like this. Only white black lines are seen. This is called as the barcode sign, or we use the word stratosphere sign. If they show you in the exam a barcode or a stratosphere appearance, then you think of pneumothorax. Then you think of pneumothorax. Okay. Also tell me, can you identify pneumothorax on a supine chest X-ray? Can you identify pneumothorax on a supine chest X-ray? If yes, then which sign? So in a erect view, air always climbs up to the apex. But in a supine, it goes down because the patient is lying supine. It goes to the lower part of the chest and you see a sign called as deep sulcus sign. So which condition shows a deep sulcus sign? Always remember pneumothorax on a supine film. Can you see, okay, another question is, can you identify pneumoperitoneum or a pneumomediastinum? Okay. If you have a hollow viscous injury in the mediastinum, we will call it pneumomediastinum. Okay. In the pneumomediastinum, you will see the entire diaphragm in continuity lined by air. Name the sign. This is called as the continuous diaphragm sign, seen due to pneumomediastinum. If you have pneumomediastinum in a child, you will see thymus outlined by air. That is called as the Spinnaker sail sign, or remember the word angel wing sign. Sometimes if you have pneumomediastinum, air is seen as a triangle or a V between the aorta and the left diaphragm. That is called as the Nacclerio V sign. That is called as the Nacclerio's V sign. Okay, so can you remember these words? Pneumomediastinum on chest X-ray can show continuous diaphragm sign, Spinnaker sail sign, angel wing sign, Nacclerio V sign. Nacclerio V sign. Potential one-liners in the exam. Okay. Now we will go one by one and look at some pathologies in the chest. Okay, bacho. I will label the anatomy. You just need to interpret for me. This is your trachea. This is an opacity, a disease which is appearing white. And the smooth line that you see here is your horizontal fissure. Because only the pleural surfaces like the fissure can appear so smooth. This is your horizontal fissure. So trachea is pulled towards the opacity and the fissure is pulled up. Fissure is pulled up. I will write it down, beta. If you ever see in your exam trachea and fissure are appearing pulled towards the disease. That means there is evidence of volume loss. If the volume is lost, then it is a collapse. If the volume was maintained, we will say consolidation. This is a patient with right upper lobe collapse. Okay, why? Because there is evidence of volume loss. The trachea is pulled towards the disease. The fissure is pulled up. Pleural surfaces on a chest X-ray appear more white, more smooth, more smooth. Can you see the pleural surfaces are more smooth? Okay, beta. Next question. In the next image, you will again appreciate that the trachea is pulled. Trachea is pulled towards the opacity. The lower border of the opacity is smooth. That is the fissure. That means we are dealing with a patient with right upper lobe collapse. The only thing that we are not able to explain is why is the central part of the fissure pushed down? A collapse cannot push the central part down. So it looks like a right upper lobe collapse, but the central part of the fissure is pushed down. If you see the central part pushed down, then there must be a tumor in the center pushing the fissure down. This is called as the Golden's S sign. This is one of the signs which is telling you the patient has a bronchogenic cancer. Patient has a cancer in the center causing right upper lobe collapse. Now before we go on, we need to write down few lines about, okay, so maybe I can add a page here. So few questions or one-liners I can give you about tumors, which I see some of you are asking. What is the tumor in the lung apex called as? If you have a tumor in the lung apex, it is called as the Pancoast tumor, which can also be called as the superior sulcus tumor. All lung cancers, we do a CT scan. All lung cancers, we do a CT scan for staging, but in Pancoast tumor, MRI is the IOC, because we have to see for the brachial plexus invasion, which can be seen on MRI. This patient can develop ptosis because of presence of Horner syndrome. Because of presence of Horner syndrome. Okay, bachcho. Which lung cancer shows cavitation? Which lung cancer shows cavitation? Answer is squamous cell cancer. Which lung cancer shows paraneoplastic syndromes, brain metastasis? Which lung cancer shows paraneoplastic myasthenic syndromes and also cerebral metastasis? Then the answer will be small cell cancer. Then the answer will be small cell cancer. Increased calcium is squamous cell. Increased calcium will be squamous cell. Okay. So brief notes on some brain tumor, lung cancers. Okay, beta. Now if I show you a X-ray in which there is a triangular opacity, this is the opacity that I'm marking for you. There is a triangular opacity which is obscuring the cardiac border, obscuring the right cardiac border. Where is the disease located and what is the sign? So if the right cardiac border is obscured, it can only be obscured by the middle lobe because it is in anatomical contact with the heart. So that means we are looking at a patient with right middle lobe collapse. Name the sign. This is called as the silhouette sign. If the right cardiac border is obscured in the question, this is the silhouette sign which tells you it is the right middle lobe disease. Some of you may ask me why it is not consolidation. Consolidation will have air bronchogram. Collapse usually will not have air bronchogram. This is the right cardiac border which is getting obscured by this triangular opacity. Are you able to do it, beta? Okay, bachcho. So this is again a possible question in your exam. Okay, bachcho. This is what I meant when I told you I want you all to now look at the trachea and tell me what is the trachea. Central. Trachea appears central. Neither push nor pull. There is a opacity in the right side which is limited by the fissure, but the opacity, everyone look at the center, opacity has air-filled bronchi visible. Air-filled bronchi, if they are visible, that tells you it is a air bronchogram. So trachea is central, air bronchogram visible. These are the signs that you see classically in your pneumonia patient. This is a mnemonic consolidation. The sign is air bronchogram. They might ask you, can you give me any other cause of air bronchogram? Can you give me any other causes of air bronchogram? In a preterm baby, if you have white lungs with air bronchogram, think of hyaline membrane disease. If you see white lungs with air bronchogram in a patient with inflammation going on in the body or sepsis, then think of ARDS. Okay. Always remember, air bronchogram is classically seen in consolidation, also seen in hyaline membrane disease and ARDS. These are possible questions in your exams. Okay, which bacterial pneumonia is common in alcoholics, diabetics, in the upper lobe of the lung, causes bulging of the fissure downwards? If you see the horizontal fissure is bulging downwards in this bacterial pneumonia, then the answer will be Klebsiella pneumonia. Which pneumonia leads to pneumatocele formation? Which bacterial pneumonia leads to pneumatocele formation? Pneumatocele formation is a feature of staphylococcal pneumonia. Pneumatocele formation is seen in staph pneumonia, bulging fissure, Klebsiella pneumonia, air bronchogram, bacterial pneumonic consolidation. Okay, beta. And before I go on, I just wanted to summarize. Let's see if you can answer. If they show you a chest X-ray which has these crisscross lines, can you see this? This X-ray has these crisscross lines. Then we call it, anyone? Then we call it reticular opacity. If the chest X-ray shows reticular opacities, then the problem is in interstitium. Then it is a interstitial disease. Which infections can cause interstitial reticular opacity? Always remember, viral, mycoplasma, and in HIV patients, pneumocystis jirovecii pneumonia. But interstitial lung disease can also be seen in pneumoconiosis or in systemic collagen, systemic inflammatory diseases like rheumatoid arthritis, scleroderma. They can also cause interstitial lung disease. So don't forget, reticular opacity is a non-specific word which only means interstitial disease. I will quickly ask you a question. Let's see how many of you are able to answer. If you see reticular opacity on a chest X-ray, what does this mean? This means interstitial disease. This means the disease is in the interstitium. Okay, beta? But can you tell the etiology? Can you tell me the cause why it has happened? No. To tell the cause, I need clinical correlation. X-ray cannot tell the cause. Can you characterize the extent of the disease? Can you characterize how much is the interstitial disease on a X-ray? No. Characterize, we need a HRCT as the IOC. To characterize interstitial lung disease, we need a high resolution CT as the investigation of choice. Are you able to do it, everyone? Okay, bachcho. So we have been able to do some of the common things. Now let us try to characterize. One of the examples that I always give in my class is, this is your heart. If you take a section in which in the center you can see the heart, this must be a basal section. This is a lung base that is visible because you're seeing the heart in the center. If you see basal subpleural, that means touching the pleura, I want all of you to see with me this area beta. Can you see in the basal area, in the subpleural area, okay, okay, give me 1 second, give me 1 second. Is it now better? Is it now better? Okay, okay. Now if on your basal subpleural area, okay, in the basal subpleural area, if you are able to see these air-filled cystic spaces sitting over one another, then we call it honeycombing. Honeycombing indicates presence of irreversible fibrosis. If there is fibrosis, it will cause pull. Because of the pull of the fibrosis, the bronchi are getting pulled and getting dilated. Can you name the sign? Traction bronchiectasis. If you see in your exam these two things, basal, subpleural, honeycombing, traction bronchiectasis, we call it usual interstitial pneumonia, or we use the term UIP. We use the term UIP, usual interstitial pneumonia pattern. Prognosis, poor. Okay. Second question is, if in a patient, okay, so I'm repeating now for the children who missed. Suppose in the lung base, in the lower lobe, you see honeycombing with, okay, with pulling of your bronchi. This is called as UIP pattern. Traction bronchiectasis, honeycombing, this is called as usual interstitial pneumonia pattern, which has poor prognosis. If in a patient with ILD, CT scan shows bilateral ground glass opacities with subpleural sparing, then what will be your answer? If they say, anyone, if they say ILD, ground glass opacity with subpleural sparing, then what will be your answer? Then the answer will be NSIP, non-specific interstitial pneumonia, non-specific interstitial pneumonia, which will have better prognosis. Okay, done. Okay, bachcho, now try. Suppose you have a patient with a old tubercular cavity, just like we saw in a previous NEET PG exam. Sometimes old tubercular cavities, they get colonized by fungal ball. Are you able to identify that this is a patient where you see a fungal ball? Why this is a fungal ball? Because you can see a crescent of air surrounding it. You can see a crescent of air surrounding it. This is called as, this chest x-ray is called as the Monod sign, seen due to aspergilloma. What are aspergillomas? These are nothing but fungal balls. If you change the position of the patient, the position of the fungal ball will change. Okay? Okay, bachcho. Quick. Underlying condition is usually a tubercular cavity. Underlying condition is usually a old tubercular cavity getting colonized by a aspergillus fungus. Okay, bachcho. Next question. If a patient has asthma or cystic fibrosis, they are more likely to produce a lot of mucus in response to aspergillus spores. So when they get exposed to aspergillus spore, they have an allergic response. This allergic response leads to these, can you see it? Gloved finger like appearance. So if they show you in the exam, chest x-ray shows gloved finger appearance on in an asthmatic patient, then you have to think of allergic bronchopulmonary aspergillosis. Allergic bronchopulmonary aspergillosis. If you have a long-standing case of ABPA, what will you develop? Long-standing case of ABPA, the patient will develop central bronchiectasis. Which condition causes predominantly centrally placed bronchiectasis? ABPA. Then the answer will be allergic bronchopulmonary aspergillosis. Okay, beta. Anyone? If a patient with neutropenia has a halo-like appearance on a CT scan, what will you suspect? If a patient with neutropenia has a halo-like appearance on a CT scan, then also it is aspergillus, but then it is opportunistic infection which is called as angioinvasive aspergillosis. Then we will use the word angioinvasive aspergillosis. At this point only we will quickly mention mucor. Mucor is another fungus which has more predication for upper respiratory tract in diabetes. So if in a diabetics, your contrast MRI shows a dark turbinate, because of the turbinate getting totally necrosed and infarcted, then the answer will be mucormycosis. Then the answer will be mucormycosis. Always remember, diabetic patient, MRI showing a dark turbinate due to necrosis of the nasal turbinates, think of mucormycosis. Okay. Now, even if you treat a patient for TB, the cavity, the destruction that has happened, that empty space will remain. Okay, so that can be filled up with the fungus. That is the risk with old tubercular cavities. Okay, I will show you an ultrasound image and any one of you can tell me the appearance. What do you see? This, okay. So what we will do is, another few images, then we can plan a break also. Some of you are asking for a break, so give me 1 second and we'll try to do it. So this is an ultrasound of the liver. The appearance is called as the cartwheel appearance. Cartwheel appearance on ultrasound seen in hydatid cyst. Okay. Don't get confused in the exam. If they say cogwheel appearance on ultrasound of the liver, if they say cogwheel appearance, that is not hydatid, that is candidiasis. Okay. Second possibility is, okay bacho, this is your liver, this is your spleen. Can you see in the liver multiple cystic lesions which have a crumpled membrane inside? This appearance is called as the crumpled membrane appearance. Can also be called as a serpent-like appearance. Again, the answer is hydatid. And in the dead stage, the hydatid will calcify. This is your liver, stomach, spleen, aorta. In the liver, you can see a calcified hydatid. Then the answer will be calcified hydatid cyst. So all three are possible and hydatid. They might show you a crumpled membrane or a cartwheel appearance or a calcified appearance. Okay. Always remember, in surgery they will talk about two classifications. One is Garbi, second is WHO. These are two ultrasound classifications of hydatid, Garbi classification and WHO classification. Can you identify hydatid on a chest X-ray? Can you have a hydatid in the chest X-ray? Yes. Hydatid, if it is partially ruptured on a chest X-ray, can look like this. It can look like a cavity or with a air fluid level with daughter cyst floating on the top. This kind of appearance has been called as the water lily sign, also called as the Camelot sign. These are chest X-ray signs of hydatid cyst. Chest X-ray sign of hydatid cyst. But don't get confused in the exam. If they mention drooping lily, it is not hydatid. Drooping lily is seen in duplication of kidney on IVP. Drooping lily is seen in duplication of kidney in IVP if the upper pole is non-functional. If the upper pole is not functional. So don't get confused. Water lily seen in hydatid. Drooping lily seen in. Drooping lily sign is seen in your duplication on IVP with the upper pole non-functioning. Don't get confused in the exam. Okay. Another possibility in the exam always is this. They might simply show you dilated bronchi. Irreversible dilatation of the bronchi is called as bronchiectasis. Bronchiectasis on a CT scan can show three signs. Name the signs. Tram track appearance, signet ring appearance. Any other? Any other you can tell me? Bunch of grapes appearance. If they show you bronchiectasis and they say patient has situs inversus, sinusitis and bronchiectasis, then the answer will become Carter-Jenner syndrome. Carter-Jenner syndrome. If they say bronchiectasis with upper lobe predominance and pancreatic insufficiency, anyone bache? If they say bronchiectasis in the upper lobe with pancreatic insufficiency, then you will mark the answer as cystic fibrosis. Then you will mark the answer as cystic fibrosis. Okay. Are each one of you able to do it? Okay, bacho. Okay. Do you want to take a 10 minutes break and then we continue? Okay. I think some of you are getting a little overwhelmed. So what we can do is we can take a quick 10 minutes break and then we will come back. Okay. 10 minutes break, then we'll come back, and then after we will do another session, then we'll take the lunch and then end. Okay. So what I'll do is I'll cover almost everything, but in a crisp, concise manner, because this is a rapid revision. Okay, start back. Yes. Okay. So welcome back, and so I hope you can already see in the purpose of the class is to keep the content but do a quicker review so that you have a broad idea of everything that is required, and all the key points are there in the images. So you can see now whatever I am writing in this PDF, this will be uploaded. This entire video will be uploaded for you. I will put that video in a single video for you for rapid review. You can revise the video in a 2x manner, or you can just simply revise the notes. It is just up to you how you want to revise, or if you want to revise system wise, you can use the DVT. So DVT will be more system wise review. Live rapid revision is topic wise review. So far I have shown you the normal CT of the brain hemorrhages, stroke, pulmonary embolism, aortic dissection, chest X-ray anatomy, pleural effusion, pneumothorax, FAST, and common infections, common signs. Are you with me? Give me a thumbs up so that I can go further and discuss more concepts with you. Just give me a quick thumbs up. Okay, bacho. Now in the next image, I want you to see this particular finding. Can you see there is a ring-like lesion with central destruction? If you see a ring-like lesion with central destruction on a chest X-ray, it is called as cavitation. It is called as cavitation. Can you tell me any condition in which you have cavitation? TB. Cavitation is a feature in tuberculosis. Primary or secondary? It is seen in secondary TB. Primary TB will not have cavitation, secondary TB cavitation. Can you tell me which cancer can have cavitation? Anybody remembers my discussion? Squamous cell cancer can have cavitation. Can you tell me very fast, any one of you can recall an answer? Okay. Can you tell me any other, any systemic disease, or, if you have a patient with IV drug abuse with multiple cavities, if you have a patient with IV drug abuse and multiple cavities in the lung, what will you call it? Then you think of septic emboli. Then you think of septic emboli. And the systemic condition with cavities in the lung will be Wegener's granulomatosis. Wegener's granulomatosis. These are some causes of cavitations on a chest film. Okay, bacho. If you see something similar to a cavity, but you see a clear-cut air fluid level, if you see something like a cavity on a chest X-ray, but it has a air fluid level visible, if you see a air fluid level, then you will call it as a lung abscess. Then you will label the condition as lung abscess. Okay. If you see multiple small nodules, okay, I'm zooming in beta. Can you see multiple soft 2 to 3 millimeter nodules throughout the lung? If you see multiple 2 to 3 millimeter millet seeds like nodules, then this is miliary appearance or miliary TB. Why do you have miliary TB? Miliary TB is due to hematogenous dissemination of tuberculosis. Can you tell me any other causes of miliary appearance? Any other infections which can cause miliary appearance? Histoplasmosis. Any other? Varicella. Similar appearances can also be seen in silicosis and sarcoidosis as well. So don't forget, miliary appearance is classical of TB, but not always TB. It can also be seen in histoplasma, varicella, silicosis, sarcoidosis. Another classic question that you will see when you see in testicular cancers, RCC, or any other malignancy which is showing hematogenous dissemination. Can you see both the lungs have multiple random cannonball-like appearance? Anyone? Then you call it as metastasis. Okay, bachcho. What is common between both of these? Both of them are hematogenous dissemination. TB is an infection. As a result, the nodules are small like millet seeds. Cancer will be larger because it is growing. You will see cannonball appearance, metastasis. Okay, then you call it pulmonary metastasis. Okay, bacha. Other than hematogenous, any other spread? Some infections take the route of the bronchus. They spread along the bronchial tree. They spread along the bronchial tree and they cause a appearance like this. Name the appearance. This is called as the tree in bud appearance. In which condition do we see tree in bud appearance? Classical of endobronchial spread of infections, most commonly tuberculosis. Most commonly tuberculosis. Okay. Now, can you name a malignancy that you read in gynae which can have a snowstorm appearance on chest X-ray due to millet small nodules of metastasis in the lung? Snowstorm appearance on chest X-ray is choriocarcinoma. Don't get confused. If they say snowstorm appearance on ultrasound, hydatiform mole, then that is a molar pregnancy. Snowstorm appearance on ultrasound is a molar pregnancy. Snowstorm appearance on chest X-ray is metastasis from choriocarcinoma. Okay, bachcho? Okay, beta. Also remember, TB ADA level should be high. Okay, in TB the ADA level is raised. But remember, in the last INI-CT paper in the exam, they asked in one of the INI-CT, tree in bud appearance, low ADA. So then the answer was not TB. Then we have to think of other infections like fungal infections. So ADA in TB should be high. Then only we can go for TB. Endobronchial TB, the appearance on CT is called as tree in bud appearance. Tree in bud appearance. Now in TB, the second possibility is you may be able to see hilar lymph nodes. Are you able to see this asymmetric only one side hilar lymph node? Yes. Lymphadenopathy can be seen in tuberculosis. Which type? Primary TB. Lymphadenopathy is a feature of primary tuberculosis. It is a component of Ghon's complex. It is a part of Ghon's complex. If the Ghon's complex calcifies, it is called as Ranke's complex. Then we call it Ranke's complex. Okay, bacha. Second question, anyone can answer. Tubercular lymph nodes on CT scan show. Tubercular lymph nodes on CT appear matted. And because of central necrosis, the appearance is called as rim enhancement only. The center is not enhancing. Why? Because it is necrotic. Tubercular lymph nodes will be asymmetric, matted and rim enhancing. Because the TB lymph nodes are necrotic, we have to differentiate from another disease which is similar to TB in its pathology. Anyone? What do you see? Lymph node, unilateral, bilateral. If the lymph nodes are bilaterally symmetrical, non-necrotic hilar lymph nodes, then you need to mark the answer as sarcoidosis. If the lymph nodes are bilaterally symmetrical, then it is sarcoidosis. Angiotensin converting enzyme in this case will be high, calcium will be high. Can you mark this? Can you name the chest X-ray staging used in sarcoidosis? Can you name the chest X-ray staging used in sarcoidosis? That is called as Skading's. Skading stages of chest X-ray. That is called as Skading stages of chest X-ray. Can you name the X-ray signs? This X-ray appearance is also called as Garland sign, or we use the word 1, 2, 3 sign on chest X-ray. These lymph nodes are called as Garland-like appearance or 1, 2, 3 sign on chest X-ray seen in sarcoidosis. Now the sarcoidosis can also be assessed on a gallium 67 scan. On a gallium scan, the physiological uptake should only be seen in the nasopharynx. If you also see the uptake in the both lacrimal glands and parotid glands, it looks like a panda. We will call it panda sign. In the chest, gallium scan will lead to lambda sign. These are both signs of sarcoidosis. Panda sign, lambda sign are seen in sarcoidosis. Don't get confused. I'm writing a confuser here. Face of giant panda on MRI brain seen in. Face of giant panda on MRI brain seen in Wilson's disease. Then don't mark sarcoidosis, then the answer will be Wilson's disease. This is a two pandas that we need to remember in radiology. Face of giant panda on MRI of the brain is Wilson's disease. Okay, so this page is about sarcoidosis. Can you think of an occupational disease in which you develop bilateral upper lobe predominant fibrosis? Upper lobe predominant fibrosis along with calcified hilar nodes, which are called as eggshell calcification. Anyone? Eggshell calcification is classical of silicosis. Can be associated with tuberculosis. Can be associated with tuberculosis. Predominant location upper lobe. Predominant location upper lobe. This has to be differentiated from a shipyard or a roof worker in which they will show you pleural calcification. Pleural calcification has undulating margins like this. Pleural calcification on X-ray is called as, this appearance is called as holly leaf sign. Name the condition. Fibrosis more in lower lobe predominance, asbestosis. Asbestosis causes fibrosis in the lower lobe with pleural calcification. But it can also cause cancer. It is a carcinogen. It can be associated with bronchogenic cancer as well as mesotheliomas. Association, bronchogenic cancer and mesotheliomas. So these are some classic chest X-ray questions that we always expect in the exam. Just to cover some more one-liners here, anyone can, some of you were asking actually in the chat. So crazy pavement appearance on CT with milky white appearance in the bronchoalveolar lavage. Anyone can answer this? Crazy pavement appearance on CT, milky white appearance on bronchoalveolar lavage that some of you were asking earlier is alveolar proteinosis. Then you think of alveolar proteinosis due to macrophage disease causing accumulation of surfactant in the alveoli. This is pulmonary alveolar proteinosis. Another question that comes to my mind here only is, In which condition do we see head cheese sign on CT? Head cheese sign on CT. You might have studied this in your respiratory medicine. This is the sign of long-standing hypersensitivity pneumonitis. Long-standing hypersensitivity pneumonitis. And the patient will be written as a farmer in the question. Hypersensitive pneumonitis, head cheese sign on CT. These are some one-liners that they sometimes ask directly in the exam. Okay. Now, just like in the revision, I focused on brain anatomy, I will focus now on chest anatomy. I want you to see this section through the superior part of the mediastinum. In this superior mediastinum, I want you to see the anatomy with me. The anterior flat bone that you see here is your sternum. That is the sternum. And posteriorly, you can see the vertebra. Posteriorly, you can see the vertebra. In between, you can see the mediastinal vessels which we need to label. Always remember, just behind the sternum there are veins. So just behind the sternum, what is the structure? Vein. Which vein? Right brachiocephalic vein. Just behind the sternum you can see the vein. On the right you will have the right brachiocephalic vein, also called as the right innominate vein. On the left side you have the left brachiocephalic vein. This is your left brachiocephalic vein. How to identify? Just behind the sternum you should have the veins. Okay, now try with me beta, all of you. Let us see how many of you can answer. I will just take a color, separate color now. Now behind the veins you have the arteries. I want you to identify this artery. The first artery arising from the arch of aorta is your brachiocephalic artery. This is your brachiocephalic artery. Next to the brachiocephalic artery you have your left common carotid. Left common carotid. And the third branch which comes from the arch of aorta is your left subclavian artery. Left subclavian artery. Okay. Now the dark air-filled structure labeled as T is the trachea. Behind the trachea there is a muscular tube, collapsed muscular tube with air inside, little bit air there, that is esophagus. That is your esophagus. This is the anatomy of the superior mediastinum. Always keep in mind there is no branch of aorta behind the esophagus. There is no branch of aorta behind the esophagus. If you see a branch of aorta behind the esophagus, then think of aberrant right subclavian artery. If you see a branch of aorta behind the esophagus, that is aberrant right subclavian artery causing dysphagia lusoria. Okay, so this is the normal anatomy of the upper part of the mediastinum. If you take a section at the level of the sternal angle, then you should be able to see the superior vena cava. Both the brachiocephalic veins join to form the superior vena cava. And this large vessel that you see here is your arch of aorta. If this is the arch, now tell me what is the structure? Trachea. Behind the trachea, esophagus. If they show you a structure which is triangular in a child anterior to the arch of aorta like this, what will you think? Then that will be thymus. This is the location of thymus. If you see a tumor in this location in a patient with myasthenia gravis, if you see a tumor in this location in a patient with myasthenia gravis, that will be thymoma. Patient will have ptosis. This is the location of thymus on a CT scan in a child. Okay, bacho? Anterior mediastinum. We come down now. As you come down, this is your superior vena cava. Anteriorly you can see the ascending part of the aorta. Right next to the vertebra you have the descending part of the aorta. Ascending aorta anterior, descending aorta posterior. And the large Y-shaped blood vessel that I'm labeling now is your main pulmonary artery dividing into right and left branch. So this is your pulmonary artery dividing into the right and the left branches. Behind the pulmonary artery at this level, you should be able to appreciate the bronchi. This is the right and left bronchus. And behind the bronchus is your esophagus. That is the echolocation of the esophagus. They might ask you to go further down. If I go further down, I should see the heart. So I saw the vessels, arch of aorta, then I can see the heart. So in the cardiac area, always remember descending aorta is right next to the vertebra is the descending aorta. Okay. Then you see the left atrium anterior to it. Most posterior chamber of the heart is left atrium. The cardiac chamber, which is towards the right, in which the SVC is draining. Can you label this chamber? Right atrium. So right atrium is towards the right, left atrium is posterior. Now we are at the level of the cardiac chambers. Okay. And in the center, you can see the aortic root. This is the dilated part of the aorta which is arising from the left ventricle. This is the root of the aorta from which the coronary arteries will arise. Adjoining the aortic root, you have the right ventricular outflow tract. You have the right ventricular outflow tract. RVO. Okay, bachcho. And when you go further down, you can see the all four chambers of the heart. The rule is right next to the vertebra descending aorta. Right next to the vertebra descending aorta, cardiac chamber which has the thickest walls. Cardiac chamber which has the thickest wall is left ventricle. Thick wall, left ventricle. Most anterior is your right ventricle. Most posterior, the base, posterior is left atrium. Towards the right atrium. This is how you label the cardiac anatomy. So you will notice now that my goal is to give you an overview of everything. So I'm also revising quickly the anatomy that, in a regular class you will see we'll spend more time on all of this. But in rapid revision, less time, but I'm not missing out on anything. I'm covering everything. So many times students who join late or students who have less time, they ask this question, is this enough? Enough. Okay. So sir, what is difference? So in a regular class, the discussion, explanation will be more and deep. That's the difference. But I'm trying to give you all the important points in the rapid revision, beta. Okay, beta? Okay, bacho. So these are the anatomical considerations in the your cardiac conditions. Okay, bacho. Second thing. Sometimes a patient can have fluid or edema in the lungs, which will be called as pulmonary edema. There are two reasons that we always should keep in mind. The first thing we should know is one cause of pulmonary edema is if you have left ventricular failure, pulmonary capillary wedge pressure will increase. If you have left ventricular failure, pulmonary capillary wedge pressure will increase. What do you call it? This will be called as cardiogenic pulmonary edema. This will be called as cardiogenic pulmonary edema. What will be the earliest X-ray sign? The first X-ray sign of cardiogenic edema will be cephalization of blood flow. Cephalization of blood flow. Followed by interstitial edema, which will be seen as curly lines. First you will have B lines, then A lines. interstitial edema, which will be seen as curly lines. In the interstitial edema stage, you can also see fluid in the horizontal fissure, which is called as phantom tumor. And the third stage will be when you develop the bat wing appearance. You develop the bat wing appearance. These are findings in a patient with cardiogenic edema. Second thing I want you to remember for your NEET PG will be, if you have a systemic inflammatory process ongoing, systemic inflammatory disease ongoing like acute pancreatitis, sepsis, then entire lung will be white. There will be diffuse opacity in the lung on the chest X-ray, that is called as ARDS. What will happen to the cardiac size in this patient? Cardiac size will be normal. There will be no bat wing predominance. Whole lung will be white with air bronchogram in ARDS, and the cardiac size will be normal. And the question will give you a hint of systemic inflammation. This is non-cardiogenic edema. Okay. This is non-cardiogenic pulmonary edema in the question. So let us try to apply this on an image. Suppose they show you a X-ray like this. What has happened to the cardiac size? In this patient, when you look at the X-ray, the cardiac size appears enlarged. There is cardiomegaly. Also, you can see a pacemaker device. If there is only one lead visible, if you see only one lead in the pacemaker, it should be in the right auricle. If there are two leads, then right ventricle also. Remember, if there are two leads, then one will be in the auricle, one will be in the right ventricle. This can be asked in the exam. If there is only one lead, then it will be in the right auricle. If two leads, then right ventricle also will have the lead. Okay, so there is cardiomegaly. Now in this patient we have cardiomegaly. I am zooming in. Can you see there are some horizontal lines touching the pleura going medially? Horizontal lines starting at the pleura going medially. What do you think these are and what is the significance? These horizontal lines are called as the curly B lines. These are horizontal lines at the lung base seen in left ventricular failure. This patient is having heart failure. Some of you might ask me, sir, where will you see curly A lines? Curly A lines are seen radiating from the hilum. Curly A lines are seen radiating from the hilum. First you will see B lines at the base, then A will come later on. So most commonly you will see the curly B lines. Okay, second image. Patient comes to emergency with breathlessness and there is cardiomegaly. The heart size is enlarged. Do you see any opacities? Do you see any opacities? Yes. The opacities are in the lower lobe, lower zone. Are they more in the central part or the peripheral part? Central lower zone predominant opacities. Name the condition. Then the answer will be, anyone? The answer will be bat wing appearance seen in cardiogenic pulmonary edema. Bat wing appearance seen in cardiogenic pulmonary edema. Okay, bacho? Okay. So we have seen some classic questions on cardiac and non-cardiac pulmonary edema. Are you able to do it? Okay. So let's do a tough question. In which condition will you see photographic negative bat wing appearance? Tough question now. In which condition will you see photographic negative bat wing appearance? Then the answer will be chronic eosinophilic pneumonia. It is reverse of bat wing. Then the answer will be chronic eosinophilic pneumonia. Here the opacities will be upper zone peripheral predominant. Upper peripheral opacities will be seen in chronic eosinophilic pneumonia. Are you able to do it all? Okay. Now some bachas are saying, sir, how will we identify cephalitis? They will not ask you. It is very subtle finding. Okay. Some places I just want you to remember the line. Cephalization means in normal person, because of gravity, lower lobe vessels will be more in diameter than the upper lobe. In cephalization, the upper vessels become more dilated as compared to lower. It is very subtle to identify. They will not ask you to identify in the NEET PG or INI set. Their X-ray images are very poor quality in the exam. They will only ask you in the words. Earliest X-ray feature of heart failure is. Then the answer is cephalization of blood flow. Okay, bacho? Okay, beta. Now try and answer this. Is the cardiac size normal, enlarged? There is massively enlarged cardiac silhouette. There is massive cardiomegaly. Is this heart failure? Okay, Swati and everybody who are getting confused. Now tell me, is this heart failure? No. Why this is not heart failure? Because there is lungs are clear. There is no pulmonary edema. It is not possible to have such a massive heart with clear lungs. Lungs are clear. And there is no single chamber enlargement. There is no specific single chamber enlargement. The entire heart is enlarged like a money bag or like a flask. Then the answer is pericardial effusion. So if you see a massively enlarged heart with clear lungs and no signs of a specific cardiac chamber enlargement, the answer will be pericardial effusion. What is the investigation of choice? What is the IOC for pericardial effusion? Investigation of pericardial effusion is a routine two-dimensional echocardiography. Can you see this now? There is pericardial fluid visible around the heart. This is a two-dimensional routine echocardiogram done for pericardial effusion. Okay, next question. Let's try now. Okay, beta. Next possible question that is always asked in your exam is congenital heart disease. Okay. Suppose you are suspecting a congenital heart disease. Before I look at the X-ray, what clinical finding do you want to ask? Before I tell you the X-ray, what clinical finding you need to see in patients with congenital heart disease? You always need to see if there is cyanosis or if there is no cyanosis. Can you do it, beta? You want to see if there is cyanosis or no cyanosis. If there is cyanosis, we want to see if there is reduced vascularity in the lung, which is called as oligemia, or there is increased vascularity, which is called as plethora. Okay. First you will see if there is cyanosis or not, then oligemia, plethora. If there is oligemia and the heart is shaped like a boot, if there is oligemia, heart is shaped like a boot due to the right ventricular contour, cardiac size is not much enlarged, then the answer will be tetralogy of Fallot. If there is oligemia and the heart is enlarged, the right atrium is enlarged, giving rise to a box-like heart, box-shaped heart, oligemia, cyanosis, then the answer will be Epstein's anomaly. Remember, mother has taken the lithium drug, Epstein's anomaly. Okay. If you have congenital heart disease with plethora, cyanosis with plethora, and your heart is shaped like, okay, let's use a different color. Heart is shaped like snowman, figure of 8, cottage loaf. If there is cyanosis, plethora, heart is shaped like snowman, figure of 8, cottage loaf, then the answer will be TAPVC, total anomalous pulmonary venous connection. If the patient is a newborn, if the child is a newborn with cyanosis, lungs have plethora, and heart is like egg on side. If the heart is like egg on side, then it will be a uncorrected TGA, uncorrected transposition of great arteries. Then the answer will be uncorrected transposition of great arteries. Are you able to do this table? Okay. If there is no cyanosis, okay, so let me create a table on the side. If there is no cyanosis, but the chest X-ray has plethora, congenital heart disease suspected, chest X-ray plethora, no cyanosis, then it could either be a AST in the question or VST. If the left atrium is normal, it is AST. If left atrium are also saying it is enlarged, then VST. If the left atrium normal, AST, enlarged, VST. If there is no cyanosis, but there is a figure of 3 appearance on chest X-ray with radiofemoral delay clinically, radial and femoral pulse are delayed, and there is, due to presence of collaterals, inferior rib notching in 3rd to 8th ribs. If due to presence of collaterals there is inferior rib notching in 3rd to 8th ribs, all of these point to diagnosis of coarctation of aorta. Then the answer will be coarctation of aorta. Okay, so this entire PDF I will give it to you, so don't worry if you are unable to write. It is because revision is not about writing, it is more about listening and then having the notes and doing it again. Are you able to do it, beta? Okay, so this is the summary of congenital heart disease. Every year 1 or 2 questions I am already predicting will be from here. Okay, beta, now try and identify the shape and the condition. This child had cyanotic spells. What is the shape of the heart? Boot shaped heart. Cor and Sabbath heart. Tetralogy of Fallot. This is your boot shaped heart or tetralogy of Fallot appearance. Okay, bacho, next. Anyone? Name the shape, and the child has cyanosis. Anyone can tell me the shape? Figure of 8. Snowman-like appearance. This is your total anomalous pulmonary venous connection. Total anomalous pulmonary venous connection. If they ask you which type, then it is supracardiac TAPVC. Then it is supracardiac TAPVC. Okay, bacho, try. Newborn baby has cyanosis. The lungs have areas of increased vascularity. Can you see there are more blood vessels visible at my marked area? So there is plethora. Newborn baby, plethora, cyanosis. All of this is pointing towards transposition of great artery. The appearance is egg on side heart. The appearance is called as egg on side heart. In tetralogy of Fallot, the patient cannot be newborn with cyanosis because tetralogy of Fallot cyanosis happens in childhood, not in newborn. And the oligemia should be there, not plethora. Okay, bacho. Name a condition in which you have cyanosis and there is massive enlargement of right atrium giving rise to a box-like appearance to the heart. Epstein's anomaly. Box-like heart, Epstein's anomaly. Box-like heart due to enlargement of right atrium. It is the right atrium which is enlarged due to a low position of tricuspid valve leading to a box-shaped heart in Epstein's anomaly. Okay. So very classic questions. We can always expect one question out of these in our exams. Okay. Don't forget the rheumatic heart disease. Rheumatic heart disease is a acquired heart disease. You remember this? Classically involves the mitral valve leading to LA enlargement. Can you name 3 signs of left atrial enlargement shown on the image? What is the red arrow indicating? What is the red arrow indicating? If you remember from my discussion of anatomy, this is your left auricle. This is the left auricular bulge. In mitral valve disease, the left auricle starts to bulge. What is the blue arrow indicating? Blue arrow. Blue arrow is showing us the left bronchus. Because of the left atrial enlargement, the carinal angle is showing widening. There is carinal widening. What do you see here with the black and a white arrow? You can see there are two atrial shadows visible on the right side. The one which is reaching till the diaphragm is your right atrium. Not reaching till the diaphragm must be the left atrium. Both the atria are seen. We will call it double atrial density, which is not normal. These are all signs of LA enlargement, which is seen in RHD. These are all signs of left atrial enlargement, which is seen in rheumatic heart disease. What will you see on a barium swallow in LA enlargement? Anyone? What will you see on a barium study in left atrial enlargement? Anyone can answer this question better. Then you will see posterior displacement of the esophagus. LA is the posterior most chamber of the heart. It will displace the esophagus posteriorly. Posterior displacement of the esophagus is due to left atrial enlargement. It is due to left atrial enlargement. So before we go onwards to other parts, just tell me 3 questions on some advances in cardiac imaging. Number 1. Okay, I'll just give you in format of one-liners. Coronary calcium scoring is done with which investigation? Coronary calcium scoring is done for screening of coronary artery disease. It is done with which investigation? It is done with cardiac CT. It is done with cardiac CT. Are you able to do it, beta? Coronary calcium scoring done with cardiac CT. Okay, beta. Second question. What is the role of cardiac MRI today? Myocardial disorders. I will not go for all, but remember only one or two. Like cardiomyopathies, cardiac amyloidosis, hemochromatosis. These are the conditions in which you will do cardiac MRI. And why would you do a cardiac PET scan? Anyone? Why would you mark the answer as cardiac PET? Cardiac PET is done for myocardial viability. Cardiac PET is done for myocardial viability. But if they say ventricular function, which means the stroke volume, ejection fraction, ventricular function, the gold standard is cardiac MRI. So ventricular function, the best is cardiac MRI, but viability of myocardium, it is cardiac PET. So these are the advances in cardiac imaging, the role of cardiac CT, cardiac MR, cardiac PET. Are you able to do, everyone? Okay. So these are our classic questions that we expect out of the few topics. I have looked at the neurological radiology. I have also looked at the pulmonary as well as cardiac. Now my suggestion will be, let's do some more and then take a break and then conclude, because I've already given you a break, little bit time before I again see some people asking for a break. So please, I think we can continue for a little bit more time. Give me a thumbs up if you agree. Okay. So I'm sure you all agree. I can see already you are agreeing. So we go forward with some bone x-rays. Very classical questions. They will not take too much of time. Okay, beta. So what do you see in this x-ray? In this x-ray, this is your epiphysis. This is your metaphysis. In this patient, from the metaphysis, which is appearing very dense because of osteoid production, it is appearing very dense. The tumor appears to spread into the surrounding soft tissue along the Sharpey's fibers. Can you see the tumor spreading into the surrounding tissue along the Sharpey's fiber, giving rise to an appearance called as sun ray appearance? Okay, this is the sun ray appearance. Second question, beta. Not only that, along the host bone, along the normal bone, can you see a triangular periosteal reaction? Yes. This triangular periosteal reaction is called as the Codman triangle. So you can see there is sun ray like appearance and the metaphysis of the bone, Codman triangle. And I know you already think that the answer is osteosarcoma. Correct. Radiosensitive, radioresistant. Radio-resistant bone tumor. Radio-resistant bone tumor. So this is the point where if we go back and I mark it for you, recently in one of the exams they had a question where a child had a X-ray in a child where from the diaphysis we had spiculated appearance along with Codman triangle. So there was an X-ray of a child with Codman triangle, spiculated appearance from the diaphysis, and they said CD99 positive. Is this osteosarcoma? Then it is not osteosarcoma beta. Osteosarcoma metaphysis, sun ray, spicule and Codman and CD99 positive, you will go for Ewing sarcoma. Then the answer will be Ewing sarcoma. Are you able to do it? Then the answer will be Ewing sarcoma. Are you able to do it, beta? Okay. Second image. Suppose we see a bone tumor extending beyond the bone. Must be a sarcoma and it is causing multiple layers of periosteal reaction. This is called as onion peel appearance. This is nothing but a multilamellar periosteal reaction. It is multiple lamella of periosteal reaction visible, typical of Ewing sarcoma. Ewing sarcoma, radiosensitive, radioresistant. Radiosensitive. Which bone tumor is radiosensitive? Always remember Ewing sarcoma. Which bone tumor is radiosensitive? Ewing's. Okay, everyone able to do it? Okay, beta. Now, try this. Where in this X-ray of an adult, you can see a well-defined lesion in the phalanges. A benign looking lesion in the phalanges. Always remember in the phalanges, if you see a benign looking lesion, it is usually a enchondroma. It is usually a enchondroma. Benign tumor of the phalanges, commonly seen in adults. Okay, beta. If you have multiple enchondromas, then what will you call the syndrome? If you have multiple enchondromas, you will call it Ollier's. If you have multiple enchondroma along with soft tissue hemangiomas, if you have multiple enchondroma along with soft tissue hemangiomas, then you will call it Maffucci. Then it is called as Maffucci syndrome. Okay, good. If they show you a bony outgrowth from the metaphysis growing away from the joint, growing away from the joint, then it is a benign lesion. It is not a tumor, it is a benign lesion called as exostosis. Exostosis. Any other name for exostosis? Exostosis is also called as osteochondroma. Exostosis is also called as osteochondroma. Are you able to do it? Okay, beta. Clear? Okay. Is it benign? Yes. Can you have a malignant change in this? Possible. Where? Malignant change in a osteochondroma can happen only in a cartilage cap. In the cartilage cap, you can have malignant change. But then the question is, I am sure you can answer, cartilage cap cannot be seen on X-ray or CT. It can only be seen on MRI. More than 1.5 centimeter cartilage cap is an indication for biopsy. More than 2 centimeter is usually malignant. So in the exam, be careful. If they say more than 2 centimeter, usually it's a malignancy. If you have a patient with multiple exostosis, name the condition. If you have a patient with multiple exostosis, the condition is called as diaphyseal achalasia. Then the condition is called as diaphyseal achalasia. Are you able to do it, everyone? Okay, bacho. So we have seen the common things. Now I want you to look at this X-ray with me. This is your growth plate. Is the growth plate visible? Yes. If the growth plate is visible, it is a X-ray of a child. Where is the disease? There is a well-defined central disease in the metaphysis. Metaphysis, central well-defined lesion in the metaphysis of a child which is non-expansile. It is not expanding. It is not expanding the bone. Okay. Now, is there a fracture in it? Yes, there is a pathological fracture which has happened. There is a pathological fracture which has happened. And the broken fragment from the fracture has fallen into the lesion. That means it is a cyst. It is not solid. It is empty. This is called as, anyone? Fallen leaf sign. Any other word? Trap door sign. These are signs of simple bone cyst. What is your answer? Simple, or they might write in the exam unicameral bone cyst. Okay, bacho. Age, child. Location, metaphysis. Central, trapdoor, fallen leaf sign, non-expansile. Think of unicameral or a simple bone cyst. Okay, compare with this one, beta. Anyone can tell me the age? Adult. Growth plates have fused. Location, predominantly epiphysis. Expansile, yes. Can be eccentric, yes. Appearance, so bubble, yes. Name this benign tumor which can be locally invasive. This is giant cell tumor, also called as osteoclastoma. This is giant cell tumor, also called as osteoclastoma. Benign tumor but can be locally invasive. Not like sarcoma which is going to metastasize, but locally invasive. Okay, done? Okay, beta. Now try this one. Okay, bacho. Age. The growth plate is visible. The growth plate is visible. If the growth plate is visible, this must be a child. Location, metaphysis. Is it expanding the bone? Not expanding the bone. This appears to expand the bone. It is a expansile lesion. Child with a metaphyseal expansile lesion, that tells you it is a cyst with pulsatile component with blood vessels which are pulsating. This is a aneurysmal bone cyst, popularly written as ABC. Simple bone cyst was non-expansile. Aneurysmal bone cyst will be expansile. Both of them will be seen in children in metaphysis. Both of them will be seen in children in metaphysis. Okay. So if you are able to do this much, I will give you one more image to think and tell me the age. Think and tell me the age. This is an X-ray of a child for sure. Why? Because the growth plates are visible. Location. The disease is located in the epiphysis. The disease is epiphyseal. Which tumor is seen in the pediatric epiphysis? Tumor that you see in pediatric epiphysis is always chondroblastoma. Chondroblastoma. Three things that you should always remember. Not chondrosarcoma beta, chondroblastoma. Blastoma beta, okay? Remember, it is also called as Codman tumor. On microscopy, two things remember. Giant cells visible. What type of calcification do you see in microscopy? Chicken wire calcification on microscopy. Chicken wire calcification on microscopy. Presence of giant cells. This is chondroblastoma. Chondroblastoma, also called as Codman tumor. Can you mark it in the exam? Okay, bacho. Very, very important questions from the exam perspective. Now suppose in the X-ray there is no well-defined lesion but the entire of the bone is glassy. Entire of your femur appears glassy. This is called as ground glass appearance of the bone. And the neck of the femur is deformed. Neck of the femur is deformed like a shepherd crook. Ground glass appearance, shepherd crook deformity of the bone. Can you tell me the condition? Then this is fibrous dysplasia. Then it is fibrous dysplasia. Any one of you can very fast tell me what do you expect in fibrous dysplasia on microscopy in pathology? On microscopy it will show Chinese letter pattern. It will show Chinese letter pattern. If you have fibrous dysplasia with precocious puberty, fibrous dysplasia with endocrine precocious puberty and your cafe au lait spots, name the condition. Then the condition is called as, anyone? McCune-Albright syndrome. Then it is called as McCune-Albright syndrome. So I'm very happy that you are all able to do it. This is all possible questions in the exam. Are you able to do it? Okay, done. Okay, bachcho, now try. Single lesion, multiple. Multiple. One bone, multiple. Multiple bones, bilateral, randomly distributed. These are all skeletal metastases. These metastases that I'm labeling for you are appearing more white. Metastases are appearing more white. Why are they appearing more white? If they are appearing more white, you have to think they are forming the bone. These metastases are called as osteoblastic metastasis. Osteoblastic metastasis, whenever they show in a male, remember prostate cancer. Remember prostate cancer. These metastases, remember these 2-3 lines. If you do a technetium MDP bone scan, if you have osteoblastic prostate metastasis, they will be seen as, anyone? Keep typing. Anyone? They will be seen as hot spots. They will be seen as hot spots. But if the entire skeleton is hot, if in prostate cancer there are so many metastases that the entire skeleton is hot, then you will call it super scan phenomena. Okay. So metastasis in prostate cancer can lead to hot spots. If their entire skeleton is hot, we call it super scan phenomena. Okay, beta. One more question. Okay. On this line only, I will keep writing. What about multiple myeloma? What about multiple myeloma? Multiple myeloma on a bone scan is cold. Multiple myeloma on a bone scan is cold. Metastasis is hot. Okay. So let us add a page here to make more. So multiple myeloma, cold. Metastasis usually hot. Okay. Now, are you clear, beta? Okay. So let me ask you some questions based similar to what we are talking about. Let's see if you can answer. There is one test we are saying bone scan. Bone scan is done with technetium MDP. Okay. Technetium MDP is doing bone scan. But what is DEXA scan? What is DEXA scan? DEXA scan is a machine, a small machine which is measuring the bone mineral density. It is the investigation of choice for BMD assessment. What is BMD? Bone mineral density assessment. Or they might say osteoporosis assessment. So how do you define osteoporosis on a DEXA scan? How do you define osteoporosis on a DEXA scan? Then if your T-score is less than minus 2.5, it is osteoporosis. If your T-score is between minus 1 and minus 2.5, if your T-score is between minus 1 and minus 2.5, it is called as osteopenia. It is called as osteopenia. Okay. But don't get confused. Only this DEXA scan is not enough to tell. Nowadays we add some clinical details also to do a to tell what is the likelihood of fracture. We call it as FRAX. What is FRAX? Fracture risk assessment tool. Fracture risk assessment tool. It takes in account not only the bone mineral density, it also takes the other it is taking the other clinical findings and other factors also. So it is a more comprehensive measure of fracture, risk of fractures. It's called a FRAX, fracture risk assessment tool. Okay, clear? Okay, so this is the image that I'm wanting you to know. This is a technetium MDP bone scan, in which the hot areas, the areas which are showing increased uptake, are metastatic areas. These are the hot spots indicating metastasis. Okay, bachcho. Now let me confuse you with some more questions. If they show you a skull X-ray like this with a serum electrophoresis finding, if they say serum electrophoresis and the skull is shown like this, then these are punched out lytic lesions, raindrop skull, serum electrophoresis mentioned in the question, then you will mark the answer as multiple myeloma. Then you will mark the answer as multiple myeloma. Are you able to do it? Okay. But if they use the word, don't panic in the exam, if they say salt and pepper skull, if they use the word salt and pepper skull, then the answer that I want you to mark will be hyperparathyroidism. Then we will mark the answer as hyperparathyroidism. In hyperparathyroidism, can you, any one of you, identify the finding of hyperparathyroidism which is marked by the arrows now? On the radial side of the phalanges, what do you see? This is the characteristic finding called as subperiosteal resorption of the bone. Subperiosteal resorption of the bone, salt and pepper skull, hyperparathyroidism. What else can you see in hyperparathyroidism? Brown tumors. Hyperparathyroidism, you might see brown tumors. What is the finding that you will see in secondary hyperparathyroidism due to CRF? What finding will you see in secondary hyperparathyroidism due to CRF? Then the answer will be Rugger-Jersey spine. Then the answer will be Rugger-Jersey spine. How will you localize a parathyroid tumor? How will you localize a parathyroid adenoma? Which investigation will you do to localize a parathyroid adenoma? Then the answer will be technetium sestamibi spect. To localize a parathyroid adenoma, you will do a technetium sestamibi spect, which is a very likely question in your exams. Investigation of choice to localize a parathyroid tumor will be technetium, sestamibi spect. So we've tried to put some questions on hyperparathyroidism in one place. Another point which I wanted to make here itself is, let me just add a page here just for your comfort. Okay. Suppose they confuse you in the exam and they say a child comes to you with lytic lesions in the skull which are having beveled edges leading to a geographic skull appearance. He also has a single vertebra collapse which is called as vertebra plana. एक vertebra plane हो गया, vertebra plana. Then don't mark multiple myeloma, that is not seen in children, that is seen in old people. Then the answer will be Langerhans cell histiocytosis. Then you need to mark the answer as Langerhans cell histiocytosis. A single vertebral collapse, beveled edges, geographic skull, child, all of these will point you to the answer called as Langerhans cell histiocytosis. Are you able to do all of this? Okay. Okay, done. So what we have done is we have actually looked at most of the important things by now, and what I will do is my goal for myself is, let us look at a few more images, then we go for the lunch break. Okay, 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 okay. Somebody is saying cotton wool. I'll tell you later on. So cotton wool is in Paget's disease, beta. Okay, now so far we was looking at tumors, primarily tumors and destruction of the bone. I will now look at some infections. Infection, always remember acute osteomyelitis. X-ray findings will be seen after 7 to 10 days. X-ray findings of osteomyelitis will be seen after 7 to 10 days. That is why the IOC will be MRI, which will show you bone marrow edema within 24 hours, which will show you bone marrow edema within 22 hours. Okay, so, but what happens in chronic condition? If you have chronic osteomyelitis, there will be some healing happening in form of new bone formation. Some bone will die because of the subperiosteal abscess, which will be called as sequestrum. I want you to see with me, can you see this dense white bone? This dense white bone that you see here is the dead bone. So if you see sequestrum in the X-ray, it is pathognomic for chronic osteomyelitis. It is pathognomic for chronic osteomyelitis. Is it dead bone or alive bone? This is the dead bone, which appears more dense on the X-ray. Dead bone appears more dense on the X-ray. It is sequestrum. Okay. Over the sequestrum, there is new bone formation that is visible on both sides. You can see the involucrum. You can see the involucrum. What is your diagnosis? This is chronic osteomyelitis. So the new bone that is being formed is the involucrum. Okay, bachcho? Okay, beta. Now what I'll ask you is, I'll give you some easy questions similar to this. Let's try. What will you find in tubercular osteomyelitis? How do you differentiate a pyogenic osteomyelitis from tubercular osteomyelitis? Anyone? Tubercular osteomyelitis, predominantly the X-ray will show osteoporosis with almost no periosteal reaction and no new bone formation. New bone formation and periosteal reaction are not typical of tuberculosis. They are features of pyogenic osteomyelitis. They are features of pyogenic osteomyelitis. Okay. Now, because you are answering, I will ask you one more question here only. Let's see if you can answer. What about Madura foot? Suppose somebody has Madura mycosis or Madura foot, what will you see in MRI? If you have Madura foot or Madura mycosis, what is the MRI finding? Anybody remembers? Then you will have a sign called as dot in a circle sign. Within the bone marrow, you will also have some fungal elements visible causing the dot in a circle sign. So dot in a circle sign in MRI, Madura mycetoma. Madura mycetoma. Are you able to do it? Okay, bacho. Okay. So one of the causes of dead bone was your sequestrum. And another cause of dead bone is called as avascular necrosis. Why would you have avascular necrosis in the bone? Could be seen after trauma, long-term steroids, sickle cell anemia, Caisson's disease. After trauma, steroids, Caisson's disease, sickle cell disease, you can have avascular necrosis, which can be earliest picked up by MRI. So MRI is the investigation of choice. Even if they say Perthes disease, which is idiopathic osteochondritis of the femoral capital epiphysis, then also it is MRI. So MRI is the investigation of choice for avascular necrosis. It is the investigation of choice for osteochondritis. It is the IOC for bone infarction. Can you mark it in the exam? MRI. Okay. Now, sometimes what they do in the exam is they change the infection to this. Now tell me, where is the infection located? Infection, this is a MRI of the spine in which the fat signal has been suppressed by a technique called as stir. Fat signal has been suppressed by a technique called as stir. So in stir, if you see something white, that is bone marrow edema. So there is bone marrow edema in the vertebra. Not only in the vertebra, in between disc is also involved. And you also see surrounding abscess. So this is your port spine. Okay, few questions. Investigation of choice, MRI. Investigation of choice, MRI. Most common variety, paradiscal. Most common variety, paradiscal. Earliest X-ray feature. Earliest X-ray feature of port spine, loss of disc space. Loss of disc space. Okay. Any one of you can answer very fast that if a patient with port spine comes to you with flexion deformity at the hip, what will you suspect? If a patient with port spine comes to you with flexion at the hip, you will think of cold abscess along the psoas. You will think of a cold abscess along the psoas muscle causing the flexion deformity. You will think of psoas abscess. Are you able to understand these possible questions in the exam? Okay. Another possible question that I always think in the exam is this. Anyone can identify this picture for me. The metaphyses of this child's X-ray appear broader, they appear splay. The metaphyses also have, look at the screen beta, cupping, irregularity, fraying. I will write down beta for you. Okay. This X-ray shows cupping, splaying, fraying of metaphysis. Can you name the condition? The answer will be rickets. Answer will be rickets. Very important question, very often asked. But where will we get confused in the exam? I will write some confusing lines in one go. We will try to solve them together. Suppose they change the question in the exam and they say epiphyseal dysgenesis. What will you think? Epiphyses are not properly formed. Why are they not properly formed? They need thyroid hormone to form the epiphysis. So if they say epiphyseal dysgenesis, you will mark the answer as hypothyroidism. You will mark the answer as hypothyroidism. If they say epiphyseal enlargement, Okay bachcho. If they say epiphyseal enlargement, then it is inflammation around the joint due to juvenile rheumatoid arthritis. If they say epiphyseal enlargement, it is juvenile rheumatoid arthritis. If they say punctate epiphysis, punctate calcification in the epiphysis, anyone? What will you suspect? If the epiphyses are bearing punctate, you think mother has taken warfarin. Then you think mother has taken warfarin. Okay. And similarly, I will add one page here. Just give me 1 second. Similarly, if they change the word in the exam and they say patient has pseudo fractures, also called as loser zone, also called as, anybody knows, pseudo fracture, loser zone, or they will say milkman fractures. Okay. Then you think of rickets but in adult. Rickets but in adult is called as osteomalacia. Then you think of osteomalacia, which is vitamin D deficiency in the adult. Another word that I want you to keep in mind for osteomalacia will be this. I'm sure many of you know it, but I want to tell you. Triradiate pelvis. Triradiate pelvis, codfish vertebra are features of osteomalacia. Triradiate pelvis, codfish vertebra, osteomalacia. But don't get confused from an autosomal dominant cause of dwarfism, which has champagne glass pelvis. I'm sure many of you should be able to answer. Champagne glass pelvis, dwarfism, autosomal dominant, think of achondroplasia. Then your answer will be achondroplasia. Okay, done? Okay. Some of you were getting confused between rickets and scurvy. So let us now spend a moment on this. Okay, beta. Anyone? I'm sure you can try. Anyone? Now what you see is there is elevation of the periosteum due to capillary fragility getting increased. There are subperiosteal hemorrhages. Subperiosteal hemorrhages. Now I want you to look at the metaphysis. There is no cupping. There is a dark band and a white band. If you see the dark band, this is called as the Trummerfeld zone. And the white band is called as white line of Frankel. White line of Frankel. The epiphyses are thinned out and only the peripheral ring-like margin of the epiphysis is visible. This ring-like margin of the epiphysis which is visible is called as the Wimberger's ring. Metaphysis has overgrown beyond the margin like a spur, that is called as the Pelton's spur. All this is happening due to deficiency of vitamin C, which is called as scurvy. Scurvy, the problem is in osteoid formation. It is defective osteoid formation due to problem in collagen. There is no problem in mineralization. So bone formed itself will be thin, there will be capillary fragility, there will be dense provisional zone leading to white line of Frankel, and the named signs are Trummerfeld zone, white line of Frankel, Wimberger ring, Pelton spur. Okay. So this is very important to remember. Vitamin vitamin D was rickets and osteomalacia, C is scurvy. In rickets, the osteoid mineralization is defective. Scurvy, the problem is in osteoid formation. Scurvy, the problem is in osteoid formation. So we've seen the common questions. So one of the most common diseases I want you to see with me. This patient has, anyone? Non-uniform loss of joint space. More in the medial compartment, because the medial compartment is the weight bearing compartment. So there is wear and tear of your articular cartilage more in the weight bearing compartment. I want you to answer quickly, what are these bony spurs that are visible? The bony spurs that are visible are called as osteophytes, and there is evidence of when the bone is again and again striking against each other, it gets dense. So there is evidence of subchondral sclerosis. There is evidence of subchondral sclerosis. Can I mark this? Non-uniform loss of joint, osteophyte formation, subchondral sclerosis, sometimes can even have loose body formation. Name the condition. Osteoarthritis. Osteoarthritis. Osteoarthritis in the hand in the PIP and DIP will show. Clinically, when you see the hand in the PIP in osteoarthritis, you will see Bouchard nodes. DIP, in the DIP, Heberden nodes. Heberden nodes. Clear? Okay. Heberden nodes. Now, if they show both hands and the X-ray shows osteoporosis around the joint, osteoporosis around the joint, then you think of rheumatoid arthritis. I will label it for you. Okay, let us write down. Earliest X-ray feature of rheumatoid arthritis is. Earliest X-ray feature of rheumatoid arthritis is periarticular osteoporosis. Periarticular osteoporosis. Because it's an inflammatory disease, other findings will be erosions, uniform loss of joint space, uniform or symmetric loss of joint space. So in osteoarthritis, it is more asymmetric. Only one compartment is lost. In rheumatoid arthritis, it is uniform. Can anyone tell me, can you have spine involvement in rheumatoid? Can you have spine involvement in rheumatoid? Yes. But it is usually in the atlantoaxial joint, C1, C2. Usually spine involvement is seen in ankylosing spondylitis. In rheumatoid, if you have spine involvement, it will be C1, C2, atlantoaxial joint. Okay. If they change the question and they say child has or a young adult has a red eye, X-ray shows bamboo spine, interspinous ligament shows dagger sign, there is bilateral symmetrical sacroiliitis. They mention in the clinical examination Skober's test. Remember Skober's test of SI joint? All of this is pointing towards ankylosing spondylitis. Red eye is pointing towards uveitis, anterior uveitis, sacroiliitis. Then we think of ankylosing spondylitis. But if they change the question and they say flowing wax appearance of anterior longitudinal ligament, if they change the question and they say flowing wax appearance of anterior longitudinal ligament, then you need to mark the answer as dish. What is dish? Diffuse idiopathic skeletal hyperosteosis. Diffuse idiopathic skeletal hyperosteosis. Okay, I will write it down again. Flowing wax appearance of anterior longitudinal ligament is dish. Can you give another name for dish? It is also called as Forestier's disease. Is it inflammatory or non-inflammatory? Not a inflammatory condition. What happens to SI joints in dish? What happens to sacroiliac joint in dish? They are normal. So be very careful. Ankylosing spondylitis you should have. Sacroiliitis in dish the SI joints will be spared. Okay beta. Name a condition in which intervertebral disc is calcified. Name a condition in which intervertebral disc is calcified. If your intervertebral disc is calcified, you will mark the answer as alkaptonuria. Alkaptonuria can also be written as ochronosis. Then you think of ochronosis or alkaptonuria as the answer. Okay. So you will see I am doing an overview system by system. I am going at each of them, and when you will do the DVT you will find another approach. Okay, anyone. So what you see here, soft tissue swelling, where first metatarsophalangeal joint. Finding rat bite punched out erosion. Rat bite punched out erosion. Not involving the articular margin. Not involving the articular margin, which is called as Martel sign. Name the condition. Name the condition, gout. Which new investigation can be used in gout? For gout, we can also use dual energy CT. New investigation which can be used for gout, dual energy CT. Named sign, Martel sign. That means the erosion is not involving the joint margin. It is away from the joint margin. Okay, beta. Now I will give you some names. I want you to remember them. First, you have to see in this patient, in the skull X-ray, there are multiple white cotton spots. Can you give me a name to it? Cotton wool skull. Cotton wool skull. If it is asked in your exam, don't panic. The answer will be Paget's disease of the bone. Paget's disease of the bone. Can you name any other skull X-ray signs of Paget's disease? There will be a large lytic lesion in the frontal bone called as osteoporosis circumscripta. Osteoporosis circumscripta. What happens to the skull in Paget's? It gets elongated. It becomes like a cap, which is called as Tam-O'Shanter skull. Tam-O'Shanter skull seen in Paget's disease. What happens to the vertebra? Anyone can tell me what happens to the vertebra? Picture frame vertebra seen in picture frame vertebra seen in Paget's disease. What happens to the long bones? Blade of grass appearance in the long bones. Alkaline phosphatase increased. Old man, think of Paget's disease of the bone. Paget's disease of the bone. Is this picture frame? Yes. Then what about the next one? Next one is not picture frame. That is Rugger Jersey spine. Seen due to secondary hyperparathyroidism in CRF. Rugger Jersey spine seen in secondary hyperparathyroidism due to CRF. Okay, bachcho? Okay. In which condition do we see bone within bone appearance? Somebody was asking, so I'm adding it here. Bone within bone appearance. Marble bone appearance are features of Osteopetrosis. Bone within bone appearance, marble bone appearance are features of osteopetrosis, also called as endobone formation. Endobone formation. And another finding that some of you were getting confused in the chat box is, if you see multiple fractures, I will write it down, beta. If you see multiple diaphyseal fractures in the bone in different stages of healing, you will mark the answer as osteogenesis imperfecta. Osteogenesis imperfecta. But if the child shows a multiple fractures in the metaphysis, in the corner of the metaphysis, metaphyseal corner fracture or bucket handle fracture, then the answer will be battered baby. Happy now? If they show you metaphyseal corner fractures or bucket handle fractures, then the answer will be battered baby. Okay, so I've covered a lot of ground already. So after, when you come back, maybe we've done the bones part, and now when you come back at the no, some cotton wool, Ananya, I'll take some doubts. Cotton wool more white spots. Salt and pepper will be tiny black dots in the skull. And also they will always give you some hint in the question, not directly only on the image. Sometimes it will be tough. Okay. Okay, so what we'll do is, I see many of you again and again writing in the chat box. So what I'll do is, we can take a quick lunch break, and when you come back after the lunch, I will then in one go I will finish the rest of it. Okay, so my request to you is, take a quick lunch break and come in maybe 35 minutes. Is it okay for everyone? Please be back in 35 minutes. And although we are doing the class in pieces, but we'll join it into a single video for you for later on review. Okay, please be back after the lunch break at 3 o'clock. Okay, welcome back everyone, welcome back. Okay, so now I want you all to join back. And so far what we have done is, we have looked at, I'll give you an overview in a very quick review of radiology. We have discussed everything which was required from brain. If you notice, my pattern was, I showed you the brain anatomy, routine CT and MRI images, how to differentiate between them. I've discussed about brain infections, brain hemorrhages, stroke, brain tumors, syndromes. Then I showed you chest x-ray, normal anatomy, pneumonias, collapse, the common things like sarcoids, silicosis, asbestosis, which can be asked as a question. And I also showed you cardiac conditions like heart failure and congenital heart disease, pericardial disorders, pericardial effusion. We covered almost everything out of them. Then in bone, we focus mainly on the bone tumor part, rickets, scurvy part, and the common arthritis. So this is what we usually expect in the exam. Now what I'll do is, I'll go at the abdomen of it. So we saw the chest, we saw the skeleton, we saw the brain. Now we'll look at the abdomen. In the abdomen, my goal will be, we have to see first the role of ultrasound. So if you are with me, just give me a quick thumbs up that you are able to hear me and see me. Give me a quick thumbs up that you are able to hear me and see me. Yes, everyone? Okay. So don't forget that in our abdomen, there is definitely a role of ultrasound. So there is a role of ultrasound for gallbladder diseases. Any time you see a question in your exam saying IOC for gallstones, what will you mark? You should mark the answer as ultrasound. Investigation of choice for gallstones is ultrasound. And if because of stone you have inflammation, that will be written as IOC for acute cholecystitis. Investigation of choice for acute cholecystitis is also ultrasound. Also remember, if you have a patient with jaundice, initial imaging in a patient with jaundice is also ultrasound. So these are some questions in which I always expect a radiology question. Investigation of choice for gallstone, ultrasound. Acute cholecystitis, ultrasound. Initial imaging for jaundice is ultrasound. To know if we are looking at a medical cause of jaundice or a surgical cause of jaundice. So what we have discussed so far is, I'm going to repeat for the students who are joining late. Anytime you see the word stone in the questions, please remember these questions in your exam. IUC for gallstones is ultrasound. IUC for urinary tract stone is a NCCT. Urinary tract stone, NCCT. Salivary gland stone. Investigation of choice for salivary gland stone is NCCT. Investigation of choice for salivary gland stone is NCCT. Investigation of choice for common bile duct stone. Common bile duct stone is MRCP. Okay. Investigation of choice for bladder stone, urinary bladder stone is ultrasound. Investigation of choice for urinary bladder stone is ultrasound. Now from this is where we started. So if they ever ask you gallstone, acute cholecystitis, it is ultrasound. Initial imaging in jaundice is ultrasound. Okay, bacho. Now my question to you is this, beta, anyone can answer. If on a HIDA scan gallbladder is not visualized, what is your diagnosis? If on a HIDA scan gallbladder is not visualized, what is your diagnosis? Then the answer will be acute cholecystitis. Then the answer will be acute cholecystitis. Okay. Okay. Now, so all of you, now you need to tell me what is the ultrasound sign of acute cholecystitis. Now, if I now tell you this is gallbladder, how will you identify the stones? How will you identify the stones? So my question to you is, what are these hyperechoic white things? These are the stones. And behind the stones, what is the finding? Behind the stone, we are able to see the acoustic shadow. Behind the stone, you can see this dark area called as the acoustic shadow. Very important question. And now, on the same note, I am adding a question. If in gallbladder you see comet tail appearance, what will you suspect? If in gallbladder you see comet tail appearance, what will you suspect? Then the answer will be adenomyomatosis. Then the answer will be adenomyomatosis. Don't get confused. If in uterus, anyone, if in uterus you have Venetian blind appearance on ultrasound, if in uterus you have Venetian blind appearance on ultrasound, then the answer is adenomyosis. Then the answer is adenomyosis of the uterus. Okay, common things that we sometimes get confused in the exam. Okay, now next question. Ultrasound is also indicated to differentiate a solid lump from a cystic lump. Whenever they say solid versus cystic anywhere in the body, the answer is ultrasound as the investigation of choice. My question to you is, how will you identify cyst on ultrasound? Cyst on ultrasound will be anechoic. Cyst on ultrasound will be dark, anechoic. And behind the cyst, there will be a lot of through transmission of the sound. So behind the cyst, you will see bright area. Posterior to the cyst, you will see a bright area. I want you to tell me the name of the sign. This sign is called as acoustic enhancement. Okay, so acoustic shadow is seen in stone. Acoustic enhancement is seen in cystic lesions. Cystic lesions which is a very, very important question in our exams. Okay. So these are some places where we use ultrasound in surgery. Can you see side by side? I am building up the IOC table. Okay, beta. Now tell me, any moving object in our body will demonstrate a frequency shift. Any moving object in our body will demonstrate frequency shift. So what is moving in a blood vessel? The blood cells are moving in a blood vessel. That is what is called as the Doppler effect. Using the Doppler effect, we can show the blood flow. We can show the blood flow with red and blue color. This is called as, the test that you see on the screen is called as color Doppler. The test is called as color Doppler. Very fast, I want you to tell me, red and blue color on a color Doppler indicate direction of flow. Indicate direction of flow. Flow towards the ultrasound probe is shown as red. Flow away from the ultrasound probe is shown as blue. Are you able to mark it? Okay. So moving objects demonstrate frequency shift. This is called as Doppler effect. And the color Doppler indicates direction of flow. This is how you will identify in the exam. Okay, beta. Few questions on Doppler. Okay, bacha. Let's see if you can answer. What is the investigation of choice for deep vein thrombosis? What is the IOC for DVT? Doppler. DVT means deep vein thrombosis, but the best DVT is the damaged DVT, which will happen in your city very soon. We are coming to Hyderabad next. Kolkata, Chennai, Ahmedabad rocked. Next we are coming to Hyderabad. After that we will come to Bangalore and Delhi. We are looking forward to meet you all in DVT beta. Okay. Now IOC for anyone, screening of carotid stenosis is Doppler. Investigation of choice for screening of carotid stenosis is Doppler. Okay. Doppler is also indicated in pregnancy. In pregnancy. Okay, beta. Now tell me, which artery? In patients with IUGR, you do a Doppler of the umbilical artery. Normally, you should see forward flow in both systole and diastole. What do you see in the bottom image? Okay, anyone, what do you see in the bottom image? We remember, we can see blood flow below the baseline. Blood flow below the baseline. What do you call it? What is the significance? This is the reversal of diastolic flow. Reversal of diastolic flow in the umbilical artery is a ominous sign. It indicates impending IUD. It indicates impending IUD. Reverse diastolic flow in the umbilical artery indicates impending IUD. Okay, so let me add one more page here and we will discuss slightly more on it. In pregnancy, I will tell you two more things. Remember uterine artery also. If in uterine artery, if you see persistent diastolic notch after 22 weeks, what will you suspect? In uterine artery, if you see persistent diastolic notch after 22 weeks, it means it is a predictor for preeclampsia. It is a predictor for preeclampsia. Okay. If you see fetal middle cerebral artery having increased peak systolic velocity, what will you suspect? If the fetal middle cerebral artery has increased peak systolic velocity, it is a sign of fetal anemia. It is a sign of fetal anemia. Okay, very, very important question, possible questions in the exam on Doppler. Now, very important two lines. Can anybody tell me, is this a Doppler image? No. Now what you see in front of you is a scan ultrasound done in eye to measure the axial length of the globe. To measure the axial length of the globe, we do a scan. Can anybody tell me now, is this a Doppler? No, this is ultrasound. Which type of ultrasound is this? This one is a M mode ultrasound, which can show the movement. You can see the movement. So this is used in echocardiography to see the motion of the heart walls. Used for pneumothorax. Do you remember pneumothorax, barcode appearance? We discussed this. Okay, anything. It is also used to measure fetal heart rate. Possible question in the exam. Fetal heart rate is measured on. The answer is M mode ultrasound. It is not measured on echo. M mode ultrasound, we measure the fetal heart rate. Okay, so these are some questions based on ultrasound and Doppler. Now, some people are asking what is B mode? It's a very good question. B mode or the 2D ultrasound is the routine ultrasound. The routine ultrasound that we do is the B mode or we call it 2D ultrasound. Okay, done. Okay. So quickly identify the investigation. Identify the investigation, IVP. This is your IVP in front of you. Okay. Quick, some questions for you. What is the IOC for renal trauma? Investigation for renal trauma is not IVP, it is CECT. Investigation of choice for renal trauma is CECT. But if they say patient is unstable, then what will you do? What is the investigation of choice in a patient with renal trauma who is hemodynamically unstable? Then the answer is single shot IVP. Also, I see some students are getting confused. Let me add a line here. For head injury and cervical spine injury, usually you do a NCCT. Remember, from head and spine we do the NCCT. But thorax and abdomen is CECT. Thorax and abdomen is CECT. Okay. Now, next is an image where a patient comes to you with sterile pyuria. What is the history? Sterile pyuria. Clinically, sterile pyuria is found. And one kidney is contracted calcified. One kidney is contracted calcified. What do you call it? Putty kidney, cement kidney, or we will simply say tubercular kidney. Tubercular kidney. It is a hematogenous urinary infection. Hematogenous infection of the kidney. What will happen to the bladder in this patient? Bladder, when it becomes fibrosed, becomes like a thimble. So TB leads to tubercular bladder, which is called as thimble bladder. Renal trauma IOC, CECT, unstable patient, single shot IVP. Head injury, NCCT. Remember, kidney, abdomen, thorax, always do CECT. Always do CECT, beta. Okay. Okay, identify the image. Both the kidneys in this image are large with multiple cysts. Diagnosis? ADPCKD. Autosomal dominant polycystic kidney disease. Investigation of choice? CECT. His screening of his family members will be done with? Screening of his family members will be done with? Ultrasound. Screening of his brain, I've already mentioned. Can anybody remember? Screening of his brain will be done with? MR angiogram. Screening of his brain, MR angiogram to look for cerebral berry aneurysms. Okay, bacho, let's try this. Both the kidneys The calyces are mal-rotated. The lower pole calyces are facing each other. The calyces are mal-rotated. Name the appearance. Handshake sign. Flower vase appearance. On IVP. Name the condition. Horse, shoe, kidney. Name the condition. Horse, shoe, kidney. Okay. So this is not maiden waist. In maiden waist, the kidney will not be rotated. The kidneys will be normal. Only the ureters come close. Then that is maiden waist. This is flower vase appearance. Flower vase appearance. Okay. Okay, bachcho. Let me see if I have maiden waist with me. Okay, I don't have, but I'll write down. So don't get confused. Maiden waist appearance is not seen in horseshoe kidney beta. Maiden waist appearance is seen in retroperitoneal fibrosis. Retroperitoneal fibrosis. Can you identify horseshoe kidney on a CT scan? Yes. IOC for horseshoe kidney is CCT. This is how it looks like. This is a CT image where you see kidney fused anterior to the aorta like this. Okay. This is horseshoe kidney on CECT. At the level of which blood vessel is the horseshoe kidney located? It is at the level of inferior mesenteric artery. It is level of inferior mesenteric artery. Very common questions in our exams. Okay, bacho. One of the more common question in NEET PG. Look at the distal part of the ureter and tell me what has happened. The distal part of the ureter is dilated like the head of a snake. Name the appearance. Adder head appearance on IVP. Name the condition. Ureterocele. Name the condition. Ureterocele. Okay, bacho. Identify the investigation. You can see the complete bladder and the urethra. Then the investigation is MCU. Micturating cystourethrogram. Okay, bacho, very fast. Investigation of choice for vesico-ureteric reflux is. Investigation of choice for vesico-ureteric reflux is MCU. Investigation of choice for renal scarring. Investigation of choice for renal scarring is technetium DMSA scan. Investigation of choice for posterior urethral valve is MCU. Keyhole appearance seen in posterior urethral valve. Management of posterior urethral valve. Cystoscopic fulguration. Cystoscopic fulguration of the valve. So always keep all these questions in mind. Very direct questions, they will be asked in your exam. Cystoscopic fulguration of the valve. But now look at the confusion now. In the next image you only see the urethra and only part of the bladder. Full bladder is not shown, only part of the bladder is shown. Then it is RGU, retrograde urethrogram. Investigation of choice for urethral injury. Retrograde urethrogram. Retrograde urethrogram. Part of the urethra above the pubic symphysis is prostatic. Part of the urethra above the pubic symphysis is prostatic. At the level of pubic symphysis, membranous. Below it, bulbar. The straight part, penile. Always remember, the part of the urethra above the pubic symphysis is prostatic. At the level of pubic symphysis is membranous, bulbar, then penile. IOC for urethral injury, RGU. What is the investigation of choice for bladder trauma? What is the investigation of choice for bladder trauma? CT cystogram. If CT cystogram has molar tooth appearance, if CT cystogram has molar tooth appearance, then it is extraperitoneal rupture. If the CT cystogram has molar tooth appearance, it is a extraperitoneal bladder rupture. Okay. And same place, I just want you to remind you, molar tooth in brain. Anybody remembers? I will use a different color. Molar tooth in brain. In brain, molar tooth was Joubert syndrome. In brain, molar tooth was Joubert syndrome. Don't get confused in the real exam. Okay. Now let's see some barium images. If you see on barium only the esophagus, this is barium swallow, only the esophagus, barium swallow, only the stomach and duodenum, only the stomach and duodenum, then barium meal, barium meal, also called as barium meal, upper GI. If you see the small bowel, if you see the small bowel, then it is barium meal follow through. Okay. I will give you some words to remember. Okay. Some words to remember. Duodenum, first part looks like a cap. Rest of the duodenum looks like a C. Jejunum is feathery on a barium study due to valvulae conniventes. Ileum is featureless. I will zoom in. Okay, I'm repeating now. Duodenum first part is shaped like a cap. Rest of the duodenum is shaped like a C. Jejunum is feathery due to valvulae conniventes. Ileum is featureless. What about large bowel? Large bowel has Haustrae. Can you now identify the investigation shown to you? That is a barium enema. This is a barium enema in which you can see the Haustrations. You can see the large bowel, barium enema. Okay. So common questions, let us look at some of them in the exam. If they show dysphagia to liquids and they show a dilated esophagus with bird beak like appearance or a rat tail like appearance, what is your diagnosis? Achalasia cardia. How will you confirm? Diagnosis will be confirmed by doing a manometry. Diagnosis will be confirmed by doing a manometry. Are you able to identify? Okay, very important question. Second important is this one. If they say apple core appearance, rat tail appearance, shouldering appearance, they are looking at CA esophagus. They are looking at CA esophagus. So how will you do local staging or T staging in this particular patient? How will you do T staging in CA esophagus? You need to do a endoscopic ultrasound. How will you look for distant metastasis in this patient? How will you look for distant metastasis in this patient? PET CT. You need to do a PET CT. And if they show you a corkscrew appearance of esophagus, then it is diffuse esophageal spasm. then it is diffuse esophageal spasm. If they show an ultrasound image in which you see the liver in the child, the stomach is visible which is distended, but the pylorus appears hypertrophied. This will be a 1-month-old boy with non-bilious projectile vomiting written in the question. What will you suspect? I know you know the answer. You will suspect CHPS, congenital hypertrophic pyloric stenosis. The pylorus looks like the cervix. This is called as the cervix sign. It looks like the cervix. Okay. What is the IUC for CHPS? Ultrasound. What is the ultrasound criteria? Length more than 16 millimeter, wall thickness more than 4 millimeter. Length more than 16 millimeter, wall more than 4 millimeter. Think of congenital hypertrophic pyloric stenosis. On X-ray they might mention single bubble. Just for my knowledge, can you tell me in which condition do they say double bubble appearance? Duodenal atresia associated with Down syndrome. Double bubble appearance is duodenal atresia, and always remember then the question will have Down syndrome trisomy 21 written there. Okay. Out of them usually a question is asked in your NEET PG exam. It is very common in the NEET PG exam. Okay bachcho. Now tell me what has happened and how will you manage. Now tell me what has happened. You can see in this X-ray gas below the diaphragm. Gas below the diaphragm means pneumoperitoneum. If you have gas below the diaphragm, that means there is a bowel perforation. Then you're thinking of bowel perforation or perforation peritonitis. Best X-ray. Best X-ray to look for gas below diaphragm is a chest X-ray erect. If the patient cannot stand up, then you will do a left lateral decubitus. If the patient cannot stand up, you will do a left lateral decubitus. Management will be resuscitation followed by exploratory laparotomy. You need to take the patient for an exploratory laparotomy to know why the peritonitis has happened. Can you give me some named signs, some name sign of pneumoperitoneum visible in this X-ray? In this X-ray, we can see the air in this supine film. In this supine X-ray, air is collected in the flanks of the child. Name the sign. This is called as the football sign on X-ray abdomen. I will give you some more named signs just for your completion. Wriggler sign, telltale triangle sign, doji cap sign, cupola sign. Okay, these are some named signs of pneumoperitoneum which can directly be asked as a one-liner in your exam. These are all X-ray signs of pneumoperitoneum. Okay, bacho. Now, before we go on, I just wanted to cover this here only. Suppose you have intestinal obstruction. What is the best X-ray to be done for intestinal obstruction? Anyone? What is the best X-ray for intestinal obstruction? Best X-ray for intestinal obstruction is X-ray abdomen supine. X-ray abdomen supine. Why do you do erect X-ray? Erect X-ray is done to look for air fluid levels. But can the air fluid levels can they be physiological? Up to 3 in an adult can be physiological. Up to 3 air fluid levels in an adult can be physiological. Okay, bacha. IOC for intestinal obstruction. Investigation of choice for intestinal obstruction, CECT. CECT. Okay, now try. If the dilated loops are central with valvulae conniventes, we are dealing with small bowel obstruction. If the dilated loops are peripheral with Hostrae, this is large bowel obstruction. If the dilated loops are peripheral with Hostrae, that is large bowel obstruction. Okay, and if they say, how will you diagnose intestinal obstruction on a CT scan? Always remember 3, 6, 9. Small bowel upper limit is 3 centimeter. Large bowel diameter 6 centimeter. Cecum above limit, upper limit is 9 centimeter. If they use the term string of pearls on X-ray abdomen, small bowel obstruction. Okay. And if they say small bowel obstruction, stone pneumobilia, can anybody put a 2 plus 2? Small bowel obstruction, stone pneumobilia. This is called as Rigler's triad, seen in gallstone ileus. So these are some emergency X-ray emergencies that I always want you to know for your exam. Always you should know. Rigler's triad, gallstone ileus. Okay beta, tough question coming your way. Now I want you all to look at an X-ray and tell me, is this gas below the diaphragm? Is this gas below the diaphragm? No. You can easily see there are bowel folds visible. This is bowel loop between liver and diaphragm. This is not pneumoperitoneum. What do you think? This is called as Chilaiditi syndrome, also called as pseudo pneumoperitoneum. It is a anatomical variant. It is a anatomical variant. It is not a disease. It is a variant anatomy. Should not be considered bowel perforation. This is Chilaiditi syndrome. Okay. Let me label the anatomy for the next image. This is your liver. Spleen. Left kidney. Aorta. IVC. Gallbladder. Pancreas. Are you able to see the anatomy? Okay. So we have seen almost all radiological anatomy in the class. Now I want you to identify the problem. Liver, gallbladder, right kidney, left kidney, aorta, IVC. Where is the disease? The disease is in the pancreas. The pancreas appears swollen and necrotic. Give me the diagnosis now. Acute pancreatitis. Okay. Quick questions on acute pancreatitis in radiology. Radiological IOC. Radiological investigation of choice for acute pancreatitis, CECT. Main reason for doing a CT scan in pancreatitis is severity assessment. Should be done at least after 72 hours. Should be done after 72 hours to assess the severity in a patient with acute pancreatitis. Okay. Let's answer a question now. If you have interstitial pancreatitis and you see a fluid collection less than 4 weeks, what will you call it? The name given is acute peripancreatic collection. More than 4 weeks, it is called as pseudocyst. More than 4 weeks, it is called as pseudocyst. Tough question coming your way. If it is necrotizing pancreatitis, less than 4 weeks, it will call as acute necrotic collection. More than 4 weeks, what will you call it? More than 4 weeks, you will call it walled-off necrosis. More than 4 weeks, you will call it walled-off necrosis. So there are two types of pancreatitis: interstitial, necrotizing. Okay. Okay, bacho. Now tell me, I will give you an image to diagnose. We will do it together. Look at the pancreas in the image and tell me what has happened. Look at the pancreas in the image and tell me what has happened. The pancreas is shrunken, calcified. What do you think? CT scan shows chronic calcific pancreatitis. Chronic calcific pancreatitis. Okay, bachon. Investigation of choice. MRCP better than CECT. Both are correct, but if both are in the choice, this is the sequence. Best investigation, endoscopic ultrasound. What is the MRCP appearance in this patient? Chronic pancreatitis, MRCP appearance is chain of lakes. Chain of lakes on MRCP, chronic pancreatitis. How to improve the MRCP? To improve the MRCP, you need to give the secretin to the patient. To improve the MRCP in chronic pancreatitis, you need to give the secretin to the patient. Suppose they show you image like this. This is liver, portal vein, spleen, stomach. Behind the stomach in the lesser sac, you can see a well-defined fluid collection. This is how a pseudocyst looks like, especially if the history of pancreatitis is given with 10 weeks or more than 4 weeks written, you think of pseudocyst. This is how a pseudocyst in the lesser sac of the peritoneum will look like. Okay. Now, we have seen pancreas. Better to see liver also side by side. Liver is mainly supplied by portal vein, but hepatocellular cancer is supplied by hepatic artery. Liver main blood supply is portal vein. Hepatocellular cancer main blood supply is hepatic artery. That is why we use a triple phase CT. Remember, investigation of choice for hepatocellular cancer, triple phase CT. Okay. So because it is supplied by hepatic artery, in the arterial phase you can see the enhancing tumor. So always remember, triple phase CT, hepatocellular cancer will show enhancement in the hepatic arterial phase. What will you see in the portal venous phase? Washout will be seen in the portal venous phase. What will you see in the equilibrium phase? Capsule. Capsule will retain the dye in the equilibrium phase. So I am repeating for all of you. Investigation of choice for hepatocellular cancer, triple phase CT. Enhancement seen in the hepatic arterial phase. Washout seen in portal venous phase. Capsule seen in equilibrium phase. What is the screening test for HCC? Patients with cirrhosis are at high risk for HCC. patient with cirrhosis are at high risk for HCC. They should undergo 6 monthly ultrasound for screening. They should undergo 6 monthly ultrasound for screening. Which we can see here, the tumor is only appreciated in the arterial phase, venous phase it is gone, and the capsule is retaining the dye in the equilibrium phase. This is typical of hepatocellular carcinoma, HCC, hepatocellular cancer. If I now label this barium image, the red colored arrow is labeling the cecum and the yellow color arrow is labeling the ileum. Can you now look at it and tell me what has happened to the ileum and cecum? Contracted, fibrosed. Okay. So if you ever see a question saying cecum is contracted, conical, pulled up, ileal stricture, think of a chronic inflammatory bowel disease affecting the ileocecal junction, that is bowel tuberculosis. My answer will be bowel tuberculosis. Investigation of choice for bowel TB, CT enterography. CT enterography is the IOC. Now I want your attention on the ileocecal valve. In TB, the ileocecal valve looks like this. In TB, because of the fibrosis, the ileocecal valve is distorted like this. Name the sign. Name the sign in bowel TB. This is called as the inverted umbrella sign appearance of the ileocecal valve. Which condition? Tuberculosis. This is called as inverted umbrella sign. Okay, next. Which inflammatory bowel disease begins in rectum? Involvement is contiguous. Involvement is contiguous, mucosal, begins in rectum, contiguous, mucosal. Colonoscopy shows pseudopolyposis. Long-standing disease leads to a lead pipe ahostral fibrosed colon. The condition is ulcerative colitis. So the appearance that you see in the image now is lead pipe appearance. Name the condition, ulcerative colitis. Lead pipe colon, ulcerative colitis. If a patient who is known case of ulcerative colitis comes to you with a dilated transverse colon more than 6 centimeter on X-ray, what will be your diagnosis? Then we will label it as toxic megacolon. Then we will label it as toxic megacolon. What about Crohn's disease? Which part? Any part of the bowel can be involved. Involvement is transmural. Skip lesions possible. Fibrosis will lead to strictures which will lead to string sign of Cantor, Crohn's disease. There will be fistula formations. Mesenteric border will be involved with high vascularity called as COM sign on CT. So which disease? Crohn's disease, inflammation, transmural, any part of the bowel can be involved. Skip involvement can be there. String sign of Cantor, COM sign on CT. Okay, happy? Now, fistula formation, Crohn's disease. Name the sign and the condition visible to you. This is a child with, red current stool, acute lump and pain in the abdomen, infant. This is the coiled spring appearance. Okay, And what do you think about the next one? What is this? Claw sign. If I do a ultrasound in this patient, this patient, I will see target sign, donut sign. I am sure you can answer better now. Intussusception. Claw sign, coiled spring sign, target sign, donut sign. Answer will be intussusception. Okay, anyone? If they show you barium enema with sigmoid colon showing this kind of appearance, what is the appearance? Saw tooth appearance. Sawtooth appearance in the sigmoid colon. Diverticulosis. Okay, बच्चों. What is the IOC for acute diverticulitis? Acute diverticulitis, it is not going to be barium beta. Acute diverticulitis, CCT. CCT will be the answer. IOC for acute appendicitis, CCT. Acute appendicitis in a child, ultrasound. Acute appendicitis in a child, ultrasound. Okay. Any one of you can answer very quick. Let's see if you can answer. What is the diameter cutoff for acute appendicitis? More than 6 millimeter in diameter. If your appendix is swollen more than 6 centimeter, it is inflamed. Acute appendicitis. 6 millimeter is the cutoff for diameter. 6 millimeter. Keep it in mind, beta. Okay. Name the sign and the condition. Sign is accordion sign. The haustral folds are all appearing swollen. The haustræ are swollen, giving rise to a sign like the accordion. Name the condition. Pseudomembranous colitis. Due to broad spectrum antibiotics. Pseudomembranous colitis. CT appearance is accordion sign. Any one of you wants to quickly have a coffee with me now? This is coffee bean appearance on X-ray abdomen seen in sigmoid volvulus. What will you see in barium enema in this particular case? What will you see in barium enema in sigmoid volvulus? Barium enema in sigmoid volvulus will show bird beak sign, or they might say bird of prey sign. Bird beak sign or bird of prey sign. So we have seen some common abdomen and gallbladder and liver and common things that they can ask you in the exam in the abdomen. Now before we go ahead, we also need to do a few points about breast. Identify the investigation. The investigation shown to you is mammography. What X-ray projections are visible to you? Craniocaudal, mediolateral, oblique. Craniocaudal, mediolateral, oblique. Okay, bacho. Anyone can answer. Okay. I will give you some one-liners. Maximum breast tissue is seen in. Maximum breast tissue is seen in MLO projection. MLO projection. All women more than dash years, more than 40 years of age should undergo annual screening mammography. All women more than 40 years of age routinely should undergo annual screening mammogram to look for ductal carcinoma in situ. This ductal carcinoma in situ will be seen as, microcalcification. Seen as microcalcification. Okay, beta. Family history. If you have family history, mammography should start at the age of 35 years. Mammography should start at the age of 35 years if you have family history. If you have genetic risk, BRCA positive genetic risk, then screening should start at 25 years with MRI. If you have genetic risk, then screening should start at 25 years with MRI. Let us try to identify first. This is how microcalcification looks like. It is linear and branching in pattern. Linear branching pattern of microcalcification is suspicious for DCIS. It is suspicious for ductal carcinoma in situ. Okay, so before we go on, let me just add one single page here and we will talk about it more. Okay, beta. Before I tell you BIRADS, just look at a few more lines. A young woman has a breast lump. A young woman has a breast lump. Ultrasound is the IUC. Suspected breast abscess. Suspected breast abscess. Ultrasound. Solid versus cystic. Ultrasound. Evaluation of breast implants. MRI. Keep this in mind. Evaluation on breast implants. MRI. Linguini sign on MRI. Linguini sign on MRI. Intracapsular implant rupture. Intracapsular implant rupture. Step ladder on ultrasound. Step ladder appearance on ultrasound. Intracapsular implant rupture. Snowstorm appearance on ultrasound. Snowstorm appearance on ultrasound is extracapsular implant rupture. Extracapsular breast implant rupture. Snowstorm is extracapsular, step ladder is intracapsular. Okay. Now we'll quickly ask you some questions on BIRADS. What is BIRAD 0? Inadequate for opinion. What is BIRAD 0? Inadequate for opinion. Okay, bachcho. If the mammogram is normal, it is BIRADS 1. If the mammogram is benign finding, 2. What is the likelihood of cancer in BIRADS 1 and 2? 0% likelihood of cancer. If the mammogram is probably benign with less than 2% chances of cancer, less than 2% likelihood of cancer, then we will call it BIRADS 3. Management, 6-month short-term follow-up. Okay, bache. Suspicious for cancer, BIRADS 4. Suggestive of cancer, more than 95% likelihood of cancer. Both of them we need a tissue diagnosis. We need a biopsy tissue diagnosis. BIRADS 5. Known case of biopsy proven cancer. BIRADS 6. Known case of biopsy proven cancer is BIRADS 6. So suspicious is 2 to 95%. This is what is called as the BIRADS lexicon. This is what is called as the BIRADS lexicon. So we have done in a summary the breast imaging also. And before we go on, just quick look at this image. First image is a CT image, second is a PET scan. What is the third image? What is the third image in the final miscellaneous part? This is the PET CT. This is the PET CT. Okay. Now quick. What is the most common compound used in PET CT? Most common compound that we use in PET CT is, anybody? We use FDG. What is FDG? Fluorodeoxyglucose. Cancer cells are constantly glucose hungry. They are constantly glucose hungry. As a result, this FDG is taken up by the cancer, so it is used in cancer staging and response to therapy. Cancer staging and response to therapy, PET CT. Are you able to answer this much? Okay, beta. For which cancer do we use gallium dotatate PET? For which cancer do we use gallium dotatate PET? Neuroendocrine tumor. For which cancer do we use gallium PSMA PET? Anyone? That is prostate cancer. For which cancer do we use sodium fluoride PET? Bone tumors, bone metastasis. Sodium fluoride PET, bone tumors. Are you able to answer all of this? Which tumor is FDG negative? Which tumor is FDG negative? Carcinoid. Which physiological tissue is FDG positive? Which physiological tissue is FDG positive? Brown fat. Which physiological tissue is FDG positive? Brown fat. Okay. So we have done a series of questions on PET scan. Now what I'll do is I'll make just one or two more pages on some simple ideas on radiotherapy and radiosensitivity. Number one, I want you to remember is this. One of the most common questions that you get in your exam is radiation protection. How will you protect yourself from radiation? If you are a doctor working in the radiology department, how will you protect? You will go away. You will create distance. Radiation dose is inversely proportional to square of the distance. What is this called as? Inverse square law. You will use a lead apron which should have 0.5 millimeter thick lead, and you should do radiation dose monitoring with TLD batch. TLD is thermoluminescent dosimetry. You should follow the guideline. What is the guideline for occupational radiation exposure? What is the guideline for occupational radiation exposure? 20 millisievert per annum. 20 millisievert per annum. So this is a slide on radiation protection. Second question that I see in NEET PG is radiation sensitivity. Just remember these 2-3 lines. Bone marrow is more radiosensitive than gonads, than GI mucosa. Least sensitive is always going to be in the paper, remember, nervous tissue. Least sensitive will be nervous tissue. In the cell cycle, most sensitive part of the cell cycle will be G to M followed by M. Least sensitive will be late S phase. Okay. Which blood cells? If they say blood cells, the question will always be lymphocyte. Most sensitive blood cells are lymphocytes followed by neutrophil, followed by platelet, followed by RBC. Lymphocyte, neutrophil, platelet, RBC. If they say eye, always remember lens is the most radiosensitive. If they say fetus, 8 to 15 weeks is the most radiosensitive phase. If they say fetus, 8 to 15 is the most radiosensitive phase. If they say eye, lens, remember lens is the most radiosensitive thing. Okay. And final slide which I will make here will be this. Okay, I will try to put it in very small words, not to increase it too much. Most common method of radiotherapy. Most common method of radiotherapy is teletherapy, which is also called as external beam radiotherapy. External beam radiotherapy. Okay, bachcho. Now, earlier used machine, the latest machine, preferred machine, LINAC. Now we prefer LINAC. Produces X-rays and electrons. Older machine, Cobalt machine, uses cobalt 60, produces gamma rays. Half-life 5.2 years. Most common method of radiotherapy is teletherapy. Best machine of teletherapy, LINAC, produces X-rays, while cobalt produces gamma rays. Cobalt produces gamma rays. Opposite of teletherapy is brachytherapy. Brachytherapy means the radioactive isotope is kept in contact with the tumor, cavity or substance. Contact, cavity, substance. Most common isotope used in brachytherapy, iridium-192. Half-life 74 days. Half-life 74 days. High dose rate radiotherapy. Only used as a temporary implant. The doctor will not handle it. Doctor will use remote afterloaders to apply this isotope. Doctor uses remote afterloader to apply this isotope. Okay. What is unsealed radiotherapy? Unsealed radiotherapy means giving a radioactive isotope systemically. For example, you give iodine-131 systemically for treatment of well differentiated thyroid cancer. Half-life of iodine-131, 8 days. Produces both beta and gamma rays, but only the beta rays destroy the tumor. Only the beta rays kill the tumor, not the gamma. Only the beta rays kill the tumor. It is also used in treatment of Graves' disease, but it causes worsening of ophthalmopathy. It causes worsening of ophthalmopathy. Okay. Final line, beta, final. Okay. Don't forget proton beam therapy. Latest radiotherapy is proton beam therapy, which uses Bragg's peak phenomena. Bragg's peak phenomena. Hence, it is the latest radiotherapy with no surrounding tissue damage. Which radiotherapy is the latest radiotherapy with no surrounding tissue damage? Proton beam therapy. Uses which phenomena? It uses Bragg's peak phenomena for no surrounding tissue damage. Okay, so we did an attempt that we keep ourselves in the time frame and cover almost everything in radiology. So I kept the flow similar to what we keep in the regular class, and we created a rapid review for you. I hope you enjoy it. I will upload the PDF and I will also get the videos uploaded in a single video so that you can do it later on in a 2x speed. So the entire idea for this rapid revision should be 1.75x rapid review, and you will be able to do it in the from the notes itself. Okay. So before I leave you for the day, my final message for you will be, okay, my final message for you will be that now let us imagine for a moment, and suppose you are on an airport. I'm sure many of you must have seen the airport. On the airport, you will appreciate that these are how the travelators are. Remember, travelators. You can stand on them. They move by themselves. And I hope you can see there are different kind of people. Some people on the travelator, they just stand there. Some people, they walk fast. Some people run. This is life actually, where the time is running, and this is the limited amount of time that you have in your life. Some people run and make it happen. They want to, they happen to the life. Some people let the life happen to them. They are standing there. Have you seen it or not? एयरपोर्ट पे जाके देखा कई लोग ऐसे खड़े रहते बस हिल ही नहीं रहे. You understand? You are not happening to life. You're letting life happen to you. You happen to life. अपन जो चाहते करके दिखाएंगे ना. Let it happen. So that is first approach. Second thing is, in the travelator, you will see gates on the side. When you're going on the travelator in the airport, gate आ रहे होंगे. लेकिन कुछ लोग ना आपस में बातें करने में लगे होंगे. Some people, they keep talking to each other and they keep hearing what other people are saying. They miss the opportunities. दुनिया की सुनता रहेगा तो सारी opportunity miss हो जाएंगी. So you need to be the focus. Keep the focus in your life so that you follow and get each opportunity. लेकिन हर गेट तुझे अपनी मंजिल पे नहीं पहुंचाएगा. कुछ गेट खाली भी निकलेंगे. फ्रस्ट्रेट मत होइए, यही किस्मत है. कोई गेट सही निकलता है, कोई सही नहीं भी निकलता, लेकिन चांस लेना नहीं छोड़ना. Every time you see a gate which is sounding good enough for you, take the leap of faith. पहले थोड़ी पता होगा कि ये गेट काम करेगा. मुझे थोड़ी पता था कि एक दिन मैं डैम्स खोलूंगा, एक दिन आपको पढ़ाऊंगा लाइव. आप जैसे होशियार बच्चों को पढ़ाने का मौका मुझे 25 साल मिलेगा, मुझे थोड़ी पता था. बट कीप फेथ, टेक द लीप ऑफ फेथ टू बिगिन. You will always begin slow and you will begin small, but one day you will reach where you want to reach. Okay, keep this in mind, beta. Happen to life. Don't let life happen to you. Happen to life. Don't be the person who is standing on the travelator. Walk fast, run fast, make it happen. Take your chances. Don't keep waiting कि दुनिया बताएगी तब जाऊंगा. Take your chances. Not every gate will work out. सच कह रहा हूं, हर चीज वर्कआउट नहीं करती. मेरी भी नहीं करती, आपकी भी नहीं करेगी. बट जितनी करेंगी वर्थ इट होंगी. In the end, just have faith. His plan is always bigger than my wishes. 25 years earlier, I could never have thought that I would get a chance to teach you all on the Damn Z-Medicos app live. All over India, students are sitting all over. Actually, if we look at the today's graph, all over world, people are sitting from, some students are attending from Dubai, some students are attending from different countries also. I could never have thought. मैं तो सोचता ना कि अपने दिल्ली में अपने घर के पास पढ़ाता रहता. मैं तो पूरी दुनिया को पढ़ा पा रहा हूँ. His plan is always bigger than my wishes. So this is what I have learned in my life, that in the end the dots will connect for you as well. Keep reminding yourself, अपना टाइम. बोलो आएगा नहीं आएगा ऐसे थोड़ी आता है. अपना टाइम अपन खुद लाएगा. Keep this in mind बेटा. हर कोई बोलेगा आएगा, ऐसे नहीं आता. अपन खुद लाएगा. I wish you all the best. Thank you for giving me a chance to touch your lives. Do let me know. जब भी जिंदगी में बड़ा मुकाम पाओ, जरूर अपने टीचर को याद करना बेटा. I wish you all the best. God bless you. Best of luck. अपना टाइम अपन खुद लाएगा. I'll meet you in DVT soon in Hyderabad, Bangalore, Delhi. Look forward to meeting you in person as well बेटा. God bless you.